Yes, everyone. Hello. How are you doing? So, yeah, good day, Antoinette. How are you doing? Tell everyone to come. Oh, tell everyone to come. There's no time. I really want us to do finish up this thing very fast. Hello, Brianna. How is doing? Yes, the attendance. Yeah, I'm doing quite better. I was supposed to come to school today, but I had an appointment. I had a PT appointment today. So, and yesterday they did drainage. So they said no, don't go anywhere yet. Say okay. So, but I'm better, very much better. Next week, you will see me there live and direct. How many are we here? 8. Let me see the attendance stuff. Yeah. Yes. Next week you have an exam. Yes, you have an exam next week. Hello. How are you doing? Welcome. Welcome. Hi. Review? No. You will use for review. You are going to use the ones I've already done before. You understand? So because I really will not I don't like making promises. I will not have time between now and your class to make that review. So for your exam 1, you have to get the review online. It's on my YouTube live. The same question, the same thing. Just go through them as much as you can. All right. Because I'm not supposed to be sitting down like this. I'm supposed to elevate my leg up. You understand? So, but this class is important because you have exam next week. That's why I had to just do it. Is that the 4 hours video? There are a lot of reviews, honestly, like of the same topics. There are a lot of reviews I've done with several classes. Pick the one that works for you. Listen, sometimes when I am not talking very fast on the reviews, because the reviews I take a lot of time to discuss questions, put it ×2. Let it go very fast. All right. That's the best way to handle it. Once you get an answer to a question, jump to the next question. You don't need to start waiting for the explanation. So that makes you go faster. Because I really need all of you to do well. And one thing you need to know is that what I've noticed, the trend I've noticed, when the first exam is not doesn't go well for people, they tend to lose the ginger, the energy. Do you understand? To attempt the next exam, or they'll be attempting the next exam with fear and anxiety, and it starts affect their score. It start will be affected. Do you understand? But when your first exam, you are scoring a 90 something in your first exam, you'll be gingered. You understand? You try very much not to go down. So please, I need you guys to take the first exam seriously. I could have organized a joint review with you and the other class. But I also told them that I can't. Honestly, I can't. Yeah, I can't. And also, you anyway, we'll discuss that later. Let me open your attendance. For your attendance, I'm going to. Today is 22nd. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So I'm expecting 15 people at least. There are other people that usually join the channel, from different countries. But I'm expecting at least 15 people to be online at every time. I'm seeing 13 right now. To be online at every time. I'll take the attendance anytime. Honestly, I'll just send you a Google Sheet, and within the next 2 to 3 minutes, you fill it in. If you don't fill it in, I'll delete it. That's how I always take my attendance. So you need to be very active. And also, I ask a lot of questions and I'm expecting you to respond. I use YouTube most times because the videos are recorded online for anybody to see. Do you understand? Zoom, most times, we just record on my laptop and I don't like it. And sometimes some people will start talking at their background and it will interrupt my class. I don't like it. So for here, I am the only one talking. So you do the listening, but you can always type on the comment section. I'm looking at it. All right. Any question you have, anytime, just cut me and talk. And I'll ask question and I'll expect everybody to answer. You understand? Here, I'm still having 13. I'm supposed to have 15. I'll take attendance anytime. You understand? It can be in the beginning or maybe when I see that there are 10 people. Or maybe towards the end. Whenever, I'll take the attendance. So this topic, I'm going to discuss it in less than 2 hours. So I need you to just give me that time. Pay attention because this is your review. As I told you, as I'm teaching, you'll be seeing that, some of those questions are what you are going to see in your exam. So I'm going to share my background now. If you have any question, please feel free to ask me. Somebody said, let me see. Hey, I just joined. How to make sure you can see us? I can see everybody. I see the people that are here. You understand? I have the record. I'm seeing the names. So, but some people, their YouTube name is not their name. So I understand that. That's why I'm going to send you an attendance sheet. Maybe anytime during the discourse. So just be active, please. Don't just go somewhere and say, I'm not looking at you. You understand? Don't. Because you will miss something and you will not like what you miss. All right? So let me share my Windows. Your exam is supposed to be... Let me see. Hold on. Your exam is supposed to be chapter 17, chapter 18, chapter 19, chapter 20, correct? No, I'll drop a Google link on this chat. See, leave the attendance thing first. Let's just discuss. We've not even started. I know how to take my attendance and I know when. So just relax. Okay, so what? Because it's not your fault that it's not your fault that we are not able to cover it up. I will remove one chapter for you. So I want you guys to prepare for your exam. Prepare chapter 17, endocrinology, blood, and what we are discussing today, the heart. You understand? So that's what you prepare. Normally, the blood vessels, that's one more topic, is supposed to be part of your discourse, but I'm going to remove it. You understand? Yes. So just please, to make life easy for everybody, prepare endocrinology. Don't joke with it. I put the video there. Prepare blood. I put the review video there. Prepare heart. I put the review video there. I even put one full exam review. Exam 1 review. You understand? For you to see the kind of questions, that where you say, what chapter are you removing? Oh yeah, I said chapter 17, 18, 19. So we are removing chapter 20 for the first exam. Chapter 20 is blood vessels and circulation. So please, just anything you are doing, I need you to focus on these 3. After today's topic, please go on that thing. look at the different reviews, because like some reviews I may discuss up to 50 questions, some another review I may discuss extra 10 questions or 15 questions. So just look at these reviews. You can even take pen, write those questions down, put the answer on that, read it over and over, know it at your fingertip, so that when you see a similar question, you'll be able to answer. That's how you prepare for exam. Do you understand? Trust me. Like when you are writing your NCLEX, you use U word, correct? You use, some people use U word, Acha. You know, like I'm bringing out a website now that's Learner's Cruise. You guys will also be using Learner's Cruise. So these are things that, you know, questions. The more questions you attempt, the better for you. What chapters are you removing? I'm removing chapter 20. Do you have exam next week? Yes, that means you are just coming. But it's okay. Yes, next week. So blood, heart, endocrine. Yes, absolutely. All right. Absolutely. Okay, guys, please let's just jump in. All right. Trust me, you can ask question at any time during the stuff. I see it. All right. I see it. I have my glasses now. So I see it. Yes, it's okay. I see it. Okay, guys, please let's jump in because I really want us to discuss this thing. Okay. I believe everybody can see my screen, correct? You can see my screen, right? Yes? Yes, perfect. 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 So today, remember, anatomy is location, 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 structure, structure, structure. Physiology is function, function, function. All right? So for the first segment of this overview of cardiovascular system, we're going to define, distinguish pulmonary and the systemic circuit. We're going to describe shape, size, you know, location. That's the anatomy, you know, of the heart itself. You remember, we are talking about the heart. Last time we discussed that cardiovascular system is heart and blood. Circulatory movement. You understand? Circulatory movement. It involves three things. What is moving? Where is it moving from? And what is pushing it to move? Make sense? What is pushing it to move is the pump, which is the heart. Where is it moving from? That is the blood vessel. That's through what channel is it moving? That's vessels. And what is moving? Blood. Do you understand? Circulatory system. You understand? So it's different from cardiovascular. Cardio is just two things: cardiovascular, heart, and blood vessels. No blood. All right. So you guys should remember this in case of they're asking you exam. Your exams are very simple exams, but people fail simple exams more than hard exams because you see some people going to read very difficult things. Do you understand? Very, very, very difficult things. It's just like I just they just sent me a copy of this. This is a copy of an exam from one of the other schools. Do you understand? And I looked at the question and I started laughing. Funny enough, some people will still fail this exam. This is 150 questions. Very, very. I'm not laughing because it's cheap for me. No, but I'm laughing because these are things I mentioned to them. Just like, for example, they will give somebody an exam now. This particular question now in the exam, they say, cardiovascular system involves the following, except. You will see that person still picking, still leaving blood behind to go and pick heart. Do you understand? Like, it's that simple. Nobody, you guys are not doing anatomy major or physiology major. This is, you are just doing it as your prereq. Do you understand? So nobody's trying to make you an anatomist all of a sudden, but we just want you to understand, you know, concepts. All right. Now, when you're talking about pulmonary, you're talking about systemic. It's just two divisions of the circulatory system. Two major divisions. Put it in your head. One, lungs. The other one, not lungs. You understand? One, lungs. That's blood that gets to the lungs. That is one complete circuit. The other one is blood that gets to every other place that is not what? Lungs. That is systemic in the system. All right? So the pulmonary circuit is from the right side of the heart, right? So usually when blood enters from the right side, you know, the atrium goes to the ventricle, the right ventricle. It has to leave the heart, and it leaves the heart, you know, to the lungs. That is what? Pulmonary. Gets oxygen, comes back to the heart. Then the heart now pumps it out every other place. Do you understand? So that is the difference between pulmonary and systemic. So the pulmonary carries blood to the lungs for gas exchange and back to the heart. Then systemic supplies oxygenated blood to all tissues of the body and returns it what? To the heart. At the end of the day, that blood still comes to the heart. That's why the heart is the pump. All right. So the heart is now divided into two sides. We have the right and we have the what? The left. We have the right and we have what? The left. Now, what do you need to know? Of course, you can see this in the next 5 years. You can always see this video, right? If you just go to the live stream, anytime you have time, like after this class, just go to the live on the channel. You will see everything I've done live. Just pick your own topic that you are interested in. Even when you are not handling my class, maybe like pharmacology, pathology, some of them I will still start using this YouTube to upload the reviews and the classes. All right. I never thought about it all this while. All the while I keep using Zoom. And the problem with I have with Zoom is that it's after it records and saves it on my laptop. And I don't like that. You get? I don't like that. So students are not able to see it later on. It doesn't make sense. Yes, now 5 years. 5 years. Don't you know 5 years you'll be comfortable in your house, eating your money. And I say, let me remember this guy that even taught me that year. Let me go and look for his video. Let me see. And now go to the one video. You say, Nchebe, where are you? Where are you? You know, that kind of thing. Anyway, that's by the way. So, guys, the chambers of the heart is divided into 4. There are 4 chambers of the heart. We have 2 auricles and 2 ventricles. We have the right and the left. As I'm talking to you right now, I want you to just be imagining this thing in your mind eye. You can even be demonstrating your body as I am doing. Do you understand? That's the best way to get this thing. Now, the blood enters from the right side, right, through the biggest veins. I don't have to be on. No, you don't have to be on camera. That's even one thing about this. You don't have to be on camera. Do you get? No. I just want a situation whereby nothing will distract people that will be watching this video later. Make sense? So you can always type, I will respond, accordingly. Okay, so blood enters the right side of the heart through the vena cava. Do you understand? Superior and inferior vena cava. The superior vena cava carries blood all the way up from up. Inferior carries blood all the way from down. And that deoxygenated blood enters the right part of the heart, crosses the tricuspid valve and goes to the ventricle, right? Still on the right side of the heart. That's exactly what we have here. So fully oxygenated blood arrives from the lungs. Leave that. That's the left side. So if you look down, you see the right side of the heart. Oxygen-poor blood arrives from inferior and superior vena cava. Do you understand? And from there, it goes to the lungs and gets oxygenated, come back to the heart, and the heart pumps it out. This is just introduction. All right. So this is exactly what we are talking about here. All right. See oxygen-poor blood, this one on blue, comes to the heart. Do you understand? As it comes to the heart will pump it out. Look, I hope you can see my mouse pointer. I believe all of you can. The heart pumps it out to the lungs. It gets oxygenated in the lungs. You see, it changes to red. It comes back to the heart. Then the heart now pumps it out to the rest of the body. So this particular part is the pulmonary circuit, and this part is what is the systemic circuit. Put it in your head, and we are good to go. We can see the mouth. Okay, guys. So this is the position, the architecture of the heart, all right? Located in the mediastinum between the lungs. You should know that. Now, the base of the heart and the apex of the heart is something you need to pay attention to. Usually, when we hear apex, we are talking about, the highest structure up. It instantaneously gives you this idea of superior. But in the heart, it's opposite. Do you understand? So the apex of the heart is that down part that is pointed, all right? So it's inferior and it's tilted towards the left. Why this big broad part is the base? Do you see when people do love, they want to do love sign, how do they do it? I don't know. Let me see. They do it like this. Something like this, I don't know. I don't know how you guys do it. You guys know the best. Something like this. Whatever. So that up part, somebody's slapping at me. Yeah, so that up part is the base, guys. All right, that pointed part downwards is the apex. Don't forget. All right, in case if they give you a diagram, just that up part is the base. And think about it, it's the base because it also has a lot of big vessels attached to it, like what? The aorta. Like what? The aorta. Even the vena cava. Those are the biggest artery. The biggest artery is aorta. The biggest vein is vena cava. They are attached at the base, not the apex. The apex is just down, pointing down at this side. All right. So if somebody's breaking your heart, please make sure they don't break the base of your heart. They can break the apex. Okay. But that base, and also, no matter how big you are, if you do your fist like this, that is the size of your heart. Do you understand? So just put that in context. So look at the base of the heart, this area. See that pointed part, the apex of the heart, pointing left downwards, right? This is the base, housing the biggest vessels, like this vena cava, like the aorta, even the pulmonary trunk, the biggest vessels. Extremely important that you have this in your head. All right. Okay. So that's about that. Now let's talk about the pericardium. The pericardium is that sheet or double wall sac that encloses the heart. It covers the heart. No. Everyone's heart is not the same size. Though. Your heart is your fist, the size of your fist. You understand? So it's just a little differences from one person to another. Okay, so the pericardium is double walled sac that encloses the heart. All right, this is the heart. It covers the heart. Now, what you need to understand is, so let me use this my stuff as your heart, not my heart. Too. So you see how this thing is now, right? If I cover this thing, so it depends on the size of that person's fist most times. Like they don't do it based on gender. You understand? So, like if you see somebody that has a small fist, now most times that's exactly the size of their heart. Do you understand? Yeah, and another thing you need to know is that some people have larger hearts because they have cardiomegaly, it's pathology, not because it's natural for them. Remember what we call pathology. Pathology is something that is not normal for you. For example, I say, oh, the size of your heart is your heart is the size of your heart is your fist, and you do your fist like this, and your fist is this small, but we check your heart, and your heart is this big. I am curious to know what the problem is. It becomes, to me, in my head, automatically, it becomes pathology. It may not be, but it becomes pathology. So that's just what we are saying. That on the average, your fist is the size of your heart. All right. Okay, so this is the heart, for example. Let me cover this heart. Pay attention, guys. Let me cover this heart. You see how I'm covering this heart, eh? So this my hand that is covering this heart is known as what? Pericardium. Make sense? It's pericardium. Now look at it very, very well. Do you notice something? I think you can see me, yes. So you notice that inside of this my hand, this palm side is touching the heart. But this part, still part of the pericardium, is not touching the heart. So there is a space in between here. So it's a double sheet. It's just like you bring two clothes to cover something. Or better still, let me use this, my glass stuff, to do example. Look at this thing now. So if this thing is pericardium, do you understand? See? It's two sides, right? Now, imagine I use it to wrap up, as in this is the heart. I use to wrap up this heart. So did you notice something? It's wrapping up the heart. But if you notice, there are two sheets to it, one up and the other one down. That one down that is touching the heart itself is what we call visceral pericardium. But that one up, which is still part of the pericardium because it's double sheet, but it's not touching the heart directly, is called what? Parietal pericardium. And this space in between the two of them, you see this space now in between the two of them, we call it what? Pericardial cavity. In that pericardial cavity, there is a little fluid, 5 to 30 ml of pericardial fluid. Do you understand? Just like today, no, not today. They did me drainage yesterday, not today. And they removed about 70 mils of blood on my knee. Do you get? So I am now imagining the amount of blood, the amount of fluid in that pericardial cavity. That's how I want you guys to think. And that fluid is very aseptic, no microorganism in it. Now think about it. If microorganism enters that fluid and it becomes infected, what do you think it will lead to? Pericarditis, because itis is anything that has to do with inflammation in your body. Think about it. When your brain is inflamed, they say you have a meningitis, the meninges of your brain. When your appendix is inflamed, we say you have an appendicitis. When you have an infection in the vagina, we say you have vaginitis, urethritis. Do you understand? What else? The conjunctiva of the eyes, we say conjunctivitis. So anything inflammation is what? Itis. So the inflammation that occurs as a result of infection of that pericardial cavity or the fluid in that pericardial cavity is known as what? Pericarditis. Exactly. Exactly. So I need you guys to understand it. The difference between parietal pericardium and visceral pericardium. All right? Aha. And another thing is that parietal pericardium is fibrous in nature. It's fibrous in nature. While visceral pericardium is serous in nature. All right? Okay. So let's proceed. I believe you guys understand. Please, anytime you don't understand, please call me back. Now, there is a difference between pericardium or pericardial sac and muscle of the heart. The heart has three major muscles. You understand? One is the endocardium, two is the myocardium, and three is the epicardium. It's different from the sac that or the clothes that covers it. It's more like me saying this my cloth now has two layers. One is the one is the parietal, fibrous parietal. The other one is serous viscera. Do you understand? No, that's for my clothes. Now, if I remove these clothes, I am seeing skin. Don't worry, I'm not removing any clothes. And you see skin. You understand? So this my skin has layers. That is what we are talking about here. So after that sheet, we have layers, which is what the myocardium, the endocardium, the myocardium, and the epicardium, arranged from the innermost to the outermost. The innermost is the endocardium. So if you look at this diagram, you see this innermost is what? The endocardium. Aha. Then this middle is what? The myocardium. Why this outermost part of the muscle is what? The epicardium. So this epicardium is wrapped up with the innermost part of the pericardium, which is what? The viscera. So the visceral pericardium and the epicardium is slapped up together. They are in love. They are married. Think about it that way. Do you understand? So if you look at this diagram, you see this is the serous. This is the serous pericardium, which is the innermost. That's the visceral pericardium, and this is epicardium. Both of them are in love with each other. Okay, guys. I believe you get the concept. So I move. I play too much, right? I know that's what's in your head right now. See, this boy is enjoying himself. I am. Okay, guys, let's jump into the heart. Because when they want to break your heart, they are not going to break only the muscle and the sheet. They'll break inside. So let's see what can be broken inside. So now let's identify the layers of the heart wall. Let's identify the chambers of the heart. Let's identify even the valves of the heart. Do you understand? And how these valves control what's happening in your heart. So that when somebody comes to the clinic and tell you, doctor, they've broken my heart, tell the person they did not break your heart. Do you understand? Because if they break your heart, you will not come to the hospital by yourself. We will do this dissection probably next week. All right. Somebody will volunteer the heart and we'll dissect it. Okay. So that's the cadaveric view of the heart anyway. So take your time to look at this very well. All right. I've already discussed this thing. We've talked about the epicardium and the endocardium. So I'm not going to repeat it. We've talked about the myocardium as well. I'm not going to repeat it. All right. They help for contraction and relaxation of the heart. We'll still discuss it more. We are focusing more on the anatomy, correct? Right now, we'll still jump into the physiology very soon. Say serious. Okay. Maybe you volunteer now, please. We need the heart to dissect. Okay, guys. I mentioned that we have 4 chambers, right? The right atrium and the right ventricle. The right atrium, the right ventricle, the left atrium, the left ventricle. Yeah. So the right and left atrium. Now, guys, A is above. A is always above. So the 2 atriums, you understand? They are above. Right, left, right, left, right, left. They are above. Then the 2 ventricles are below. They are inferior. What do you know, guys? What do you have to know? The ones above always receives. The ones below always give. See, listen, if you are eating something right now, stop eating that because your brain will be confused. Should you listen or should you consider eating? All right? Aha. Just listen to me and you'll be fine. Let's get this concept. The atria, they are above. The 2 of them, they are above. The ventricles are below. Make sense? The ones above always receive. They are receivers. They are universal acceptors. They are receivers. If it is blood grouping, we say that they are what? They are AB. They are universal acceptors. But the ones down, they are always givers. They are always giving and giving and giving. Do you understand? Makes sense to you? Now, that's one concept you need to have in your head. Now, another second concept you have to have in your head is the ones above are always receiving from veins. It must Any blood entering the heart must come into the heart through the vein. Must never be through the arteries. It must be through the vein. Any blood leaving the heart must leave the heart through the arteries. That is concepts. Do you understand? That is concept. You cannot think twice about it. All right. Any blood coming to the heart comes through the heart through what? Vein. Anyone leaving the heart leaves the heart through what? Arteries. Okay. We are setting fundamental rules, guys. Fundamental rules. Now let's look at the chambers of the heart. Look at the beautiful chambers of the heart. For someone that the heart has not been broken anyway. Aha. So if you look at this heart now, for example, what do you see? You see the superior vena cava, you see the inferior vena cava here. You see this first chamber, that's the right atrium, right? You see this valve here, this is a valve. We call this right AV valve. You understand? This right AV valve, you see this condyte tendane, that's the cords, condyte tendane, like the tendons, linking it to this muscle. This particular muscle is the papillary muscle that is attaching to the endocardium of the wall. All right? Yeah, so this is the ventricle, the right ventricle. You understand? This is the left atrium, and this is the left ventricle. You understand? One thing that we always give out the left ventricle is because it's the thickest part of the heart. See how thick the muscles are, but see how thin these particular muscles are. So this automatically tells you that, oh, this is low pressure. So if this is low pressure, where is it going to? It's going to where? The lungs. Because it's low pressure, it's going to the lungs. You understand? It's going to the lungs. Why this is high pressure? So it's going to where? The aorta, because the aorta is high pressure automatically. So I'm trying to show you how you read these concepts, but we are going there. We are getting there. If you are confused, please stop me so that I'll be able to explain more. All right. So we have the sulcus, atrioventricular sulcus. We have interventricular sulcus, atrioventricular, atrium, and ventricle. So this sulcus separates the atria from the ventricles. Extremely important. Then we have interventricular sulcus. This sulcus is overlies the interventricular septum. It divides the right and the left what? Ventricle. My people, it's very important that you know these concepts. You know why we are studying this thing? You want to do the normal so that when it becomes abnormal, so that let me plug this stuff. Okay. So that when you see an abnormal structure, for example, the interventricular sulcus, if you see a space, or let me say the if you see a hole in between the two of them, you understand? If you see a hole in the septum, something that is supposed to separate the left and the right, but you see a hole in it, you see that there's a problem. Why? Because deoxygenated blood can easily move to the other part of the body and spread to the systemic circulation. And before you know it, the body becomes hypoxic. That's why you see some children, they have to squint. Why are they squinting? Or some of them not even squinting, they have to valsalva, they have to bend. You bring them in, they are always tired, they are sitting down. Why? Because they need blood to flow. So that's their valsalva maneuver that they do unconsciously, sends pressure back, systemic pressure back, and that pressure closes that hole. You understand? So that deoxygenated blood will not move from the right to the left. Instead, it will go straight to the lungs and get oxygen and come back and give to that boy. So they are unconsciously compensating. But don't worry, we are getting to that. All right? For now, what I just need you guys to do is to, fall in love with the heart and appreciate it. Love it. You understand? How many people do I have here? 8. Are you sure? Let me see if now is the best time to take this attendance. Let's see. Okay, so let's continue. Oh boy, I needed to adjust because we are still moving. We still have a lot of slides to go. So guys, this is the external architecture of the heart. All right, we've already discussed these areas. This is the left, the pulmonary vein. This is the left. This is the right. This is the pulmonary artery. You understand? Okay, guys, let's continue. I'm jumping straight to this. We've already done this. So we have interarterial septum as well, just the way we have interventricular septum. We have the interarterial septum that divides the two atrium, all right? Then we have the pectinate muscles, we have the interventricular septum, we have the trabeculae canal, that's the ventricles itself, which we've already discussed. So guys, let's talk about the valves. Valves are serious business in anatomy. They are very serious business. They work like sphincters. Anything going backwards in the body is a pathology. It's a problem. Trust me. Think about it. Think. For example, you see some people that have prostate inflammation. Because of that, it blocks the urethra. You understand, the prostatic urethra. So blood that fluid that is coming down from the bladder. What happens to that fluid? It can't pass through. So what do you think happens to that fluid? It goes backwards, back up to the bladder. Sometimes they even go back to the kidney. What do you think it leads to? It leads to infection. You understand? It leads to infection. Why haven't this thing formed? Hold on, please. So it's supposed to have formed. Just a moment, guys. Just a moment. I want to create this stuff. Yeah, so the truth of the matter is that, yeah, I see your question. Sorry, I don't know how to pronounce your name. But yes, so that infection can actually go upwards. It can lead to kidney infection. It can lead to a lot of things. Do you understand? So that's why we don't want that blockage. Think about it. How do we know that maybe somebody has intestinal torsion, maybe tying of the intestine for children? You see them vomiting. Do you get? You see them vomiting. Think about it. Okay, let me give you a perfect example. No, not your computer. Come on, not your computer. I was just trying to create this one. So now let me give you guys a perfect example of what I'm talking about things not going backwards. 4 days ago. So my neighbors, they are wonderful. I'm telling you, they are wonderful. This period, I don't want to say it's good to be sick, but they were treating me like I don't know how to classify it, but it was so nice. They've not treated me like this before. Don't mind me. So, but one of my neighbors came in and said, Nchebe, you've not eaten. Hold on, let me just order you food. So she now ordered, as she said, what do you want to eat? I said, I want to eat, what did I even say I want to eat? I want to eat, you know me now, I have to be bougie. I said, I want to eat chicken. What do you guys call it now? Steak. Yes, that's what I was thinking about. Chicken steak. I said, I want to eat chicken steak. She was like, okay, wherever. I just went, looked for one restaurant. I think is it in Brooklyn or in New Jersey? And I'm here in Staten Island, though. Like, the thing is like 70 minutes difference for them to bring the food. But that's what I wanted. She ordered it, big one. And the thing just arrived there. She went downstairs. She brought it to me. I was so happy. I was just eating this thing. I said, oh Lord, is this how this life is? I can be enjoying like this every day. So I was just eating this thing. Now, I finished eating this chicken, my people. Now, I just opened the bag that they brought. Yeah, I saw something, one little container like this. I saw things, yellow things. I thought it was fruit. I took it, I ate. I threw it inside my mouth. I ate it. I swallowed it. I said, this thing is disgusting. Packed all of them, threw them away. 3 minutes later, I started feeling somehow nausea, serious nausea. Before you know it, I've run to the toilet. I vomited everything. Everything. I was looking at my steak inside my toilet. I almost cried. I said, oh Lord, oh Jesus, what is all this? Guess what that thing is? I had to go to my the waste this thing, brought out that thing and looked at it very well. Do you know what it is? Cheese. Like, why would they put cheese in steak? Like, I was so angry. I just tested one small one because I'm lactose intolerant. So, but do you notice what happened? Because of my lactose, I went into pathology phase. And because, yes, lactose intolerant. And because of that, that sphincter, that lower esophageal sphincter opened. It's opened up. Do you get? And the food I ate that is already in the stomach, that is waiting to go down to the small intestine to digest, now started coming back up. I had to vomit it. My chest was so hot. That's how GERD happens, GERD. Gastroesophageal reflux disease. That's how it happens. Do you get? He said, cleared all my sins. I was so angry. Like, Jesus. I was like, how can... And they spent almost $60 on that steak. Waited for almost 1 hour plus. 1 hour, 20 minutes for that steak. And story of my life. Let's leave that apart. Okay, guys. So let's talk about valves. So that sphincter gave way and the stuff came back. Correct? That's exactly how valves work. Valves does not want anything to what? Come up. Does not. Except that valve has a problem. You say, how do I make it to the toilet? I have my crutches now. That's why I refuse to come to school this week, because I don't want you people to see me on crutches. I don't trust you people. Some people will start laughing at me. And the next 5 years, when they see me, they say, Nchebe, you remember that year when you were disabled? My younger sister would call me on phone and say, hello, my disabled brother. My sister is crazy. Anyway, so, sorry. Yeah. Okay, so let's go back. If a valve has a problem, do you get? Let me give you an example of a valve having a problem. Have you seen people that have varicose vein? Have you seen people like some of these people that work in all these places that they have to stand for a whole long hours? Even some professors has varicose vein, but now most professors sit down. Do you understand? To lecture. So you see, the vein normally veins has valves, right? And vein takes blood upwards. So those valves stop the blood from coming downwards, right? So if the valve has a problem, you see the blood coming downwards. Some will be coming up, some will be coming down. It now causes what? Sludging. The vein will now dilate like this. Do you understand? You see a lot of nurses, exactly, because you guys stand too much. I can't relate. You understand? The vein will now swell up like this. You will now see something like snake on somebody's leg. That is very common. It is because of valvular insufficiency. All right, valvular insufficiency. So now let's talk about the valves in the heart. First off, guys, if they ask you what are the valves in the heart, don't say tricuspid, bicuspid, this one, that one. No. Of course, any pathology is not good. Once you have varicose vein, please go to the hospital, let them sort it out. All right? Yeah, because it's not normal. Anything that you see, why you are learning physiology is that anything that is not this physiology is abnormal. It's as simple as that. Normally, I'm not supposed to be seeing with using glasses. You understand? This is how normal physiology should work. But because there's anomaly, I have to use glasses to adjust, right? So trying to help my physiology. You understand? So what we are studying now is for you to know the normal, so that when you see the abnormal, you'll be able to identify it. Do you understand? Because if you don't know the abnormal, how will you be able to? If you don't know the normal, how will you be able to know that this is abnormal? You can't. You will think it's normal. All right. So valves are divided into two. We have the AV valves and we have what? The semilunar valves. Put that in your head now. I need you to put it in your head, not in your book. We have the AV valves, that's the atrioventricular valves, and we have what? The semilunar valves. The atrioventricular valves is divided into two. The right AV valves and the left AV valve. The right AV valves, another name for it is what? Tricuspid valve, because it has 3 cups. The left AV valves is what? Bicuspid valve, because it has 2 cups. Another name for it is what? Mitral valve. The 2 AVs discussed. They are called AV because they are in between the atrium and the ventricle. So atrioventricular, in between the atrium and the ventricle. Atrioventricular. Now, the semilunar valves, they look like half moon. That's why they are called semilunar. They look like half moon. And where are they found? The 2 of them are found in, one is in the lungs, in the pulmonary artery. Do you understand? Pulmonary artery. The other one is what? In the aorta. So that one in the pulmonary artery is known as what? Pulmonary valve. The one in the aorta is known as what? Aortic what? Valve. So you see how we classify the 4 of them in the heart. So 2 of them, 2 AV valves, 2 semilunar valves, 4 valves. So you need to know where they are positioned. What is their function, guys? Their function is to avoid regurgitation of blood, backflow of blood. That is their function. Don't allow blood to come upwards. Allow blood to go downwards, but don't allow it to what? Come upwards. Chicken. This is so nice. Okay. So this is, if you look at the screen, you see the AV valves. We have the chordae tendineae. Chordae tendineae, from the name, chordae tendineae. Tendineae means tendon. All right? Tendineae means tendon. What is the function of tendon? Tendon tries to link 2 things together, usually a muscle to something. You understand? A muscle to something. Sometimes a muscle to bone, most times. So if this chordae tendineae links these valves to a muscle known as what? Papillary muscle. Why you need to know this is because this chordae tendineae prevents AV valves from flipping or bulging into the atrium when the ventricle contracts. Because the ventricle contracts, and when the ventricle contracts, high pressure. So to allow it to avoid it pushing backwards, because if it pushes backwards, guys, listen, I'm saying, you may not understand what I'm saying, but let me demonstrate it. Look at me. Look at me. Look at me. Somebody's not. You are not looking. Okay, you are not looking. So this is the valve. See, fluid accumulate here. It opens up. Boom. It comes back up. Now that it comes back up, this guy here, that's the ventricle, has to squeeze to push out blood on his own, right? Has to squeeze to push out blood. That time he squeezes, the pressure here will rise. That pressure can push this guy upwards. So if this guy has a little problem, that pressure can push this guy upwards. And if he pushes it upwards, the fluid here, instead of it going downwards, we just jump back up. That's a regurgitation. You see? Now, what is stopping this valve from going upwards here is this chordae tendineae. Let me show you the chordae tendineae. Look at it, guys. I know you can see me. You see? This is the tendineae. This. Okay, let me use this valve. This is the valve. This is the chordae. You see the chordae here? This is the chordae. This is the chordae. You understand? This is the chordae. This thing. That looks like a rope. Connecting this valve to this muscle. This muscle is what? The papillary muscle. This is chordae. This chordae helps to hold it strong, so that even if this guy presses more pressure, this guy will not bulge up. What does it tell you? It tells you that if something happens to this chordae, this guy will start prolapsing. It tells you that if something happens to this papillary muscle, so look at this papillary muscle, which attaches to the chordae, which attaches to the valves. You see the sequence? So if something happens to the papillary muscle, the valve can what? Prolapse. If something happens to the chordae, the valves can what? Prolapse. Wisdom. I need you to hit your hand on your head and say wisdom. Say wisdom in your head. Put it. Keep hitting it. Say wisdom. Let it enter. So my point is that you are seeing the physiology. If somebody comes to the clinic with a heart failure, any of these components can be the cause of that heart failure. Thank you. Do you get? Anything can be a cause of heart failure. Guys, what is heart failure? What is the function? What did I tell you about the circulatory system? I told you about the substance that moves, where it moves, and the pump That pump is what? The heart. If anything happens to that pump, that means, and it's, if anything happens to the heart, which is function, major function is to pump blood, it has failed. We say heart failure. So heart failure deals with anything about what? Blood flow failure. I know that all of you passed this exam, definitely. You guys are so smart. But if there is an anomaly, maybe somebody that refuses to study, refuses to pay attention as I'm talking, that means the person didn't do his duty. Your only duty is to learn and pass. That's your duty. So if you refuse to do your duty and you write the exam, what do you think will happen? The person will fail. So when you fail when you didn't do your duty, you fail. That's exactly how the heart is. If the heart didn't perform its only duty, which is what? To cause what? Flow, to pump blood, it has failed. That's heart failure. No, myocardial infarction is not the same thing as heart failure. Myocardial infarction is, in fact, is when blood does not get to a particular architecture of the heart. But we are going to discuss it in total, all right? Don't worry. Don't stress yourself, all right? Aha. Okay, so that is valve, guys. That's valve. I just discussed the 4 valves with you. I've discussed the pulmonary and the what? Aortic valve. I've discussed them with you. So look at the diagram. You can see this diagram in your lab exam, possibly. If you look, what do you see? Assuming I didn't label anything here, how do you know which one is which? So guys, pay attention. This is a cup. This is a cup. This is a cup. How many cups? 3. So this automatically becomes what? Tricuspid valve. And tricuspid valve is which type of AV valve? The right AV valve. It's on the right. Guy, look at this guy. It has 1 cup, 2 cups. This is what? Bicuspid valve, which is also called what? Mitra. Is it mitra or mitra? Guys, is it mitra or mitra? You know, my pronunciation is terrible. Is it mitra or mitra? Okay, I know all of you are saying the same thing with me. Oh, mitra. Okay, second one, that's mitra. Okay, mitra valve. I'm learning. Thank you. So you see, so this one, so if they label this thing, you don't need to think. Like, see, guys, there's a way you learn this anatomy. You don't need to think. You should not be thinking. You should just be putting your answer, and smile out. 10 minutes. That's how you should know this thing. That's how you need to pay attention. Guys, look at this guy. This guy is red, right? This guy is red. You understand? As it is red, what does it tell you? It tells you that the blood passing through it is what? Oxygenated. Which vessel carries that oxygenated blood? The aorta. So this is aortic because it's aortic and pulmonary. This is aortic. Now this is pulmonary valve in the pulmonary artery. Remember, I told you what takes blood away from the heart is what? Artery. And in the heart, what valves are we considering? The artery valves. So this the aorta is an artery. This guy is an artery. But the beautiful thing about these 2 things is that this guy is a little anomaly, right? Arteries carries oxygenated blood, but only in the heart. You see, as far as you're an adult, only in the heart will you see the artery carrying deoxygenated blood and the vein carrying oxygenated blood. Wisdom. So you look at the diagram, you see, oh, this is blue. This must be, and this must be the pulmonary. Straight, you just put it pulmonary valve. You see this is red. This must be the aorta. This must be the aortic valve. This is 2 cups. Oh, this definitely is the mitra. That's the left. Oh, you see this is 3 cups. Ah, this is the right. This is tricuspid. Okay, I'll repeat. I'm thinking of a way to say this. I even forgot what I said, but I'll try to remember. Okay, so guys, we said what takes blood away from the heart is an artery, correct? So what brings blood to the heart is a vein, correct? All of us agree on that. We also agree that arteries carries oxygenated blood, correct? Yes. Vein carries a deoxygenated blood, correct? Yes. But look at the heart. When blood enters the right ventricle, right? It passes the tricuspid valve, goes to the right. When the blood enters the right atrium, rather, it passes the tricuspid valve, goes to the right ventricle, right? It has to go out of the heart to go and get oxygen. But at that moment, it does not have oxygen, but it has to go out of the heart. And what carries blood out of the heart? Artery. So that's why you will know that it is pulmonary artery that will take the blood from that right ventricle to the lungs. So that is the only time when you see an artery carrying a deoxygenated blood. That is why it is what? Blue. The valve in that pulmonary artery is what? This valve. And that's why it is blue, because that oxygen, that blood in it is deoxygenated. It has not been oxygenated. Now, when it gets to the lungs, it gets oxygenated, right? It has to come back to the heart. And what did I tell you brings blood back to the heart? It must be a vein. So which vein? Pulmonary vein. And now you ask, vein is not supposed to carry oxygenated blood. Yes, in the heart, vein carries oxygenated blood. And that is what the anomaly of the heart. Not just vein, pulmonary vein. Every other vein carries what? Every other vein carries deoxygenated blood, apart from umbilical vein. Let's leave umbilical vein. But every other vein carries what? Deoxygenated blood. Do you understand? But in the heart, the pulmonary vein carries oxygenated blood. That's my point. In the heart, the pulmonary artery carries deoxygenated blood. And that is why the valve in that pulmonary artery is red. Is blue, because it is deoxygenated. Yeah, the tri and the bi doesn't have redness because it doesn't really matter. You understand? It doesn't really matter. They are not classified in that sense. What they are classified is in the corpse. Perfect. Perfect. So for these two, forget about the color. But for these two, use the color to identify them and you'll be good. Trust me. It's so interesting. All right. So interesting. Okay. I need a water bottle to demonstrate this thing. Okay, none here. So, but let me continue. I don't want to start standing up before somebody will start laughing at me now. Okay, guys. Let's see how blood moves through the chambers. Somebody has already started laughing. Let's see how blood moves through the chambers. So I need you guys to look at this thing. You just need to know the sequence of how blood moves. We already discussed this thing, so I know you know it. But let me just, touch it. Blood enters the heart through these guys. This is the inferior vena cava. This is superior vena cava. It enters here. That's where we say 1. You understand? You see how it enters? This from inferior vena, superior vena cava. This arrow is from inferior vena cava. The two of them enters where? The right atrium, right? Now, this blood bypasses this valve, this right AV. That is a tricuspid valve, right? And flows into this area. This is the what? Right ventricle, correct? Yeah, so that's number. Then from the right ventricle, it has to go out of the heart. You understand? Through what? The pulmonary what? Artery. So this is the pulmonary artery. Carries the blood. This is the trunk, right? In this trunk, the pulmonary artery divides into 2. One goes to the left, one goes to the right of the lungs. So look at it. This one goes to the lung, this one goes to the lung. That's why you see 5 and 5 here. All right? When they get to the lung, what do? They become oxygenated. The blood becomes oxygenated. Blood has to come back to the heart through what? Pulmonary vein. This is why you see number 6 here. So this is pulmonary vein. This is pulmonary vein. You see? The 2 pulmonary vein. Where are they putting blood? They are putting blood in the left A, which is left atrium here. This is the left atrium. All right? So the blood from this left atrium bypasses this valve. This is the left AV valve, which is what? The mitral valve, which is also the bicuspid valve, and pours into this largest and the strongest part of the, not the largest, but the strongest part of what? The heart chamber, which is the left ventricle. They tell you the strongest part, left ventricle, guys. So this is the left ventricle. Now the blood in the left ventricle is now squeezed out through the aorta. This is the aorta here. Aorta here. That's how you see 8. You see aorta here. You understand? So here now, you see this place that I'm pointing. There is an aortic valve. Aortic valve. So it crosses the aortic valve into the aorta. Then comes the aorta, and it's now being distributed into different vessels that I'm going to discuss with you guys next week. You understand? And this goes systemic. Chicken, huh? You see? So beautiful. So don't let anybody break your heart, though, my people. Don't. Because you don't know where that person is going to break. The person can decide to go and break the valves, and, you know, you start, you know what I mean. Okay, guys. So let's circle back a little. The blood enters here, pim, 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 and goes out, right? Enters again, pim, 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 and goes out. How about the heart? I told you, I don't know if it's your class, I told you a story about a woman that she sells food and suddenly she collapsed. Why did she collapse? She has a hypoglycemia. So then you ask yourself, how can a woman selling food have hypoglycemia? Can't you just eat the food you are cooking? Like, why can't you just eat it? Then they interviewed the woman. The woman said, no, I don't eat food. I sell to my people. I have my own food. I cook for myself. Then this one is for the public. I sell to customers. Wisdom. That's exactly what happens in the heart, guys. The heart pumps blood through it, pumps blood, but the heart does not use that blood. It doesn't. Instead, the heart has its own blood supply, which are the coronary vessels. So 5% of the blood is for the heart. So 5% of blood pumped by the heart is pumped to the heart itself through the coronary circulation to sustain its strenuous work. Because the heart is working a lot. Guys, you guys work 12 hours and you're complaining, right? A friend of mine was telling me, Nchebe, do you know I work double shift? 12-hour shift, double shift, that's 24 hours. She said, this boy, you are very wicked and heartless. I said, fine, I'm sorry. Do you get? Yeah, but the truth of the matter is that you are complaining for 12 hours job, but the heart is doing 24 hours job every day of your life. If you live 100 years, guys, I know some of you here will live up to 100 years. So if you live 100 years, right, that means your heart is working for 100 years. It's even working more than 100 years. Because the truth of the matter is that if you calculate how children are, how the heart starts working in before you were born, and our age, we calculate it from when you were born. That when you were born till the next year becomes 1. How about the time when you were inside the womb? Inside the uterus. How about that time? You see, you get the wisdom. Hit your head and say wisdom, wisdom, wisdom. Wisdom wants to finish you. Do you get? So that's time. The heart works, you understand, 24 hours, never getting tired. All right? So the heart needs abundance of energy and other things. And how does the heart get that? Through the coronary circulation. And this is the coronary circulation here. You understand? Let me give you this so that it make you understand it. Yeah, the century. Yeah, make you understand it properly. If you look very well here. Now, the coronary circulation is the coronary artery is divided into the left and the right. All right, this is the left and this is the right. There are brief things you need to know. I really don't want you to start hitting your head too much about this, but there are brief things you need to know. And what you need to know, what supplies each chamber. At least, even if you don't understand anything, just understand what supplies each chamber. Which coronary vessel understands each chamber. Now, the heart is divided into two. The coronary vessel is divided into two major areas, which is the left coronary and right coronary. So that left coronary branches off the ascending aorta. They came off from the ascending aorta. All right. Now, one is the anterior interventricular branch. This anterior interventricular, anterior is in the front, interventricular in between the two ventricles. What does it tell you? It tells you that it supplies what? Both ventricles and the septum, because it's on top like this. So anterior interventricular branch supplies both ventricles. That's what you need to know for your exam. What of the atrium? What supplies them? Okay, let's see the second branch of the left coronary. So you are telling me that the anterior interventricular branch of the left coronary supplies both ventricles. Yes, I will agree with you. What about the second branch? The left coronary also have a branch known as circumflex branch. You understand? It passes the circumflex, something that passes around. You understand? So the beauty of that circumflex branch is that it gives off one major branch, which is what? The marginal branch. The marginal branch. So that marginal branch supplies the left atrium. and the posterior wall of the left ventricle. So what supplies the left atrium? The marginal branch of the circumflex branch of the left circumflex artery. The marginal of the second. Why am I having the marginal branch, right, of the circumflex of the what? LCA supplies the left atrium and the posterior of the left ventricle. But the two ventricles are supplied by the anterior interventricular branch of the LCA, left coronary artery. So you see how important the left coronary artery is. Left coronary supplies the two ventricles, supplies what? The atrium. Imagine if the left coronary is blocked. Guys, just think about it. If the left CA is blocked, what do you think will happen? Before you know it, blood will not be getting to the musculatures of the two ventricles and also of the left atrium. What do you think will happen next? Infarction. That is what we call myocardial infarction. Usually as a result of blockage of the coronary vessels. See, this is the left. What about the right? You understand? The right also branches of the ascending aorta as well. You understand? It supplies, yeah, of course. It supplies the right atrium and the sinoatrial node, as the pacemaker. I'll tell you about the pacemaker. You understand? So, but what you need to know is the right coronary supplies what? The right atrium. If you know that, you are good to go. The marginal branch, the posterior interventricular branch, all these ones is just minimal. But the right thing you need to know is that the right coronary, right atrium. Left coronary, two ventricles, and the left atrium. Okay. This is the diagram. Please look it up later so that we can move. Yes. When that coronary is obstructed, do you understand? When coronary is obstructed, it leads to chest pain. That chest pain, we call it what? Angina pectoris. Why? Because blood is not able to get to that particular place. Ischemia is happening. So pain, I keep telling people that pain is actually a good thing in anatomy. It helps the body. It's a way the body tells you, oh, something is wrong with me. Something is wrong with me. It's just like, imagine I'm not feeling pain on this, my leg right now. Somebody called me and say, Nchebe, I'm so sorry. I know you must be. I say, yes, I'm passing terrible pain. In short, they've given me a lot of medication. This one is, let me see, ibuprofen, the highest milligram, 600. This one is Cerebrex. This one is naproxen. As in a lot of things because of the pain. Do you get? So, but the truth of the matter is that the pain is a good thing. It means that my body is saying that something is wrong. My body is able to detect that something is wrong. If I pierce you on your hand now, you don't feel pain, then you have a problem. It means that your body is not able to detect that something is wrong, meaning that somebody can kill you without your body fighting. Your body is naturally built to fight. That physiology. All right. So one way, when the coronary artery is getting obstructed before even myocardial infarction, your body will start complaining. How does it complain? Chest pain. You start having chest pain because of partial blockage. Then some people will be like, let me macho it. Don't macho it. Go to the clinic. Go to the clinic. Me, sometimes I used to have chest pain if I run. I was wondering what happened. Over the years, I've never done a lipid panel before. I went to the clinic the other day. I did lipid panel. Like, the truth of the matter is that I didn't go just because of lipid panel. I went for, let me just do tests. Let me just do tests. I had insurance since I'm not using it. Let me just flex my insurance for once. I said, let me do tests and also know what's up with me because I've lost weight, you know. Lo and behold, everything was fine. Everything was fine. You understand? But what did they find? They found that my LDL is high and my HDL is low. That is hyperlipidemia. In short, when I was discussing the cardiologist, he told me that, see, if not because you are a very young person, I would have placed you on atorvastatin right now, on a statin right now. And he said, I will still place you on that statin if in the next 3 to 4 months you do not change, you do not, your cholesterol did not drop. That's why if you go to my kitchen now, I have a lot of things. I have flaxseed, I have chia seed, I have, name them. I have hemp seed. I don't eat rice anymore. I eat barley. Is it barley? I know my pronunciation is terrible. Please don't laugh. Um, I avoid cashew nut. I eat almond, walnuts. You know all those things. Do you understand? So because me, I don't because my body has told me that probably something. Yeah, quinoa. I have that one. I've not even eaten it, but I have it. I bought it 2 packs. I don't know how to make it. Yeah, or maybe I don't have time to make it. Yeah, yeah. Sometimes I don't even know how I even have the thing because I hardly eat. Today, for example, I'm not eating. This is past 2, right? This is 2:10. I've not even eaten. See, I'm not eating. So it's not even whether I was around. Like somebody was like, Nchebe, it's because you jump out of the house. I say it's not because I jump out of the house. Even if I'm in the house, sometimes I'm so busy that I will not even remember to eat. Same way I make rice. Oh, okay, okay. I made barley for the first time. I just cooked it like rice, ate it with black beans sometimes ago. Okay, I'll try that. Maybe after this class, I'll try it. Cook it with chicken broth instead of water. Oh, yes, I have chicken breast in the fridge. I don't know about Bali. Yeah, Bali. My AI told me that Bali is very, very good. So, and I have a friend. She told me she's a nursing practitioner. So she also told me that like I should try Bali instead of rice. It looks like rice actually, like half water, half broth. Oh, hello, welcome. Okay, I'll try it. So, guys, angina pectoris is the body reacting, right? Pain caused by ischemia, right? Partial obstruction. Do you understand? Why? Because if the body, if the coronary is blocked, right, the heart is not getting enough oxygen. Guys, think about yourself when you are running. You are running when you are doing exercise in the gym. You're on treadmill. You are running on treadmill. Some people run on treadmill. Like I just keep looking at them. You know me, my head. I have wild thoughts. Sometimes I'll be on the treadmill. I'll just be walking. I see somebody running on the treadmill. Me, I have very wild thoughts. I'll just be looking at immediately. I start imagining. Imagine this person just fall off and slide, and the head hits that treadmill, and I'll start laughing. I'm so evil. Anyway, that's by the way. So the thing is that if you start running now, you are running well, you are good to go, you have energy, right? Why? Because you are just burning normal, you are working on aerobic respiration, but suddenly your tissues are not getting enough oxygen again. So you start working on what? Anaerobic respiration, fermentation. And what is the product? Lactic acid. Lactic acid will start depositing on all your joints. And before you know what, you fatigue, you start tiring out. That is what happens to the heart if it's not getting enough oxygen. It will start running on what? Anaerobic respiration. And it's not supposed to do that. Before you know it, the heart will start fatiguing. That fatigue is that pain that you are feeling. And if you don't give that heart enough oxygen, with time, you understand, with time, before you know it, it will fail. To die completely. Infarction will happen. And at that moment, you can't reverse it. You understand? Like some people that have diabetes, you understand? When they have injury in their foot, before you know it, sometimes the infarction happens on the leg and we have to cut it off. If the infarction happens in the heart, what will you do? You cut the heart off. You understand? So that's myocardial infarction, sudden death of the patch of myocardium resulting from long-term obstruction of coronary circulation. Do you understand? Long-term obstruction. So what can cause those obstructions? There are some things we call what? Atheroma. Atheroma can be blood clots or fatty deposits. You understand? It obstructs the coronary arteries. You understand? Before you know it, cardiac muscle downstream, that's where it's supplying, it gets blocked and dies. Pain will start, and the pain radiates to the left arm. You understand? Before you know it, it disrupts the electrical conduction pathways, leading to what? Fibrillation, and before you know it's cardiac arrest, and the person dies. You understand? We call it silent heart attack. Sometimes it occurs in diabetic patients, which I just explained initially, and also sometimes elderly. More than 27% of deaths in America is as a result of coronary blockage. Very important that you guys understand myocardial infarction. All right? Okay. So this is drainage. When you are talking about drainage, you are talking about When you are talking about vein, carrying blood out of the muscles of the heart. All right, taking blood away, draining it. Right, and it's usually great cardiac vein, posterior interventricular vein, and left marginal veins. They won't start asking you deeper questions other than that. So you just need to know this major classification. That's why it's on red, looking at you now, for you to remember it in your head. So great cardiac vein, posterior interventricular vein, left marginal veins. All right. So look at them very well. You understand them. All of them, most of them empty in the coronary sinus. All right. Coronary sinus, coronary sinus, coronary sinus. So remember coronary sinus as well. Okay. Please, if you have any question, you can always drop it, or any comments, you can always drop it. That's fine. I will definitely respond to you. And I know I speak very fast. So sometimes if I'm speaking too fast and you are not able to get me, don't keep quiet. Please stop me. All right. Or just tell me to slow down. Or after the class, you can still go back to the video and slow it down and listen. Do you understand? All right. So please. So guys, let's go to the conduction pathway of the heart, which is the interesting part of the heart, the fun part of the heart, conduction pathway. We know that the cardiomyocytes, that's the cells of the heart, right? They are striated. Who can tell me what other tissues among the three tissues we have, what other tissues are striated? At least I need like 10 people to put an answer. Even if the same answer is fine. I'm listening, guys. Type. Let's go. Only one person here. Where is everybody in the house? Wake up. Are you sleeping? Wake up. Somebody's laughing. Talk to me, guys. Let me see. Someone's laughing. I say, wake up. Yes, now sometimes I take review, like some of your reviews, like for your second and third exam. I may be taking your review in the night. I am more active in the night. Do you get? You see somebody dozing. I know how I know. The spirit ministers unto me. Tells me, Nchebe, my son, somebody's sleeping. And if you give me the name of the person, and I'll come to the class. I will not see it on YouTube because thousands of people are going to come on YouTube and watch these videos. But I'll come to class and I'll say it. And the person will be shocked. How did Nchebe know? I know. It's the spirit. Okay, guys. You guys are so correct. The skeletal muscles are also striated. All right? Smooth muscles are not striated. Now, second question I want to ask. What makes skeletal muscles striated? You guys did a AP1, so you know that. What makes skeletal muscles striated? That striation, what is it? Come on, guys. Okay, we have one answer. The band, the myosin. Keep going, guys. Keep going. Chat, keep going. Actin, I'm not sure. Okay, That's fine. Like if you are not sure, guys, I forgot to give the rule. If I ask a question and you don't know the answer, don't keep quiet. Just write 911. All right, not sure. All right, emergency. Anything that comes to your head. All right, all right. Wisdom, wisdom. Too much wisdom. Hey, Nchebe. Okay, you guys are close to correct. Yes, it's actin and myosin. Yes. So that actin and myosin overlapping the light and the dark band, those alternating light and dark bands, that's what causes what? The striation. But for the heart, what causes striation in the cardiac muscle is what? Intercalated disc. Intercalated discs, they are just when the cardiomyocyte is this one cardiomyocyte, this another cardiomyocyte. That in between each of them is what? The striation, right? Can you repeat the question, please? Oh, I am asking. I asked which other muscle tissue? We have skeletal muscle, we have smooth muscle, we have cardiac muscle. I said which one has striation? And the answer is cardiac and skeletal. We already discussed cardiac, so everybody mentioned skeletal, which is absolutely correct. All right. Now I'm not asking what is the cause of that striation for skeletal? And the cause is actin and myosin overlap. Actin and myosin, when they lap, they form dark band. Only myosin, light band. So that alternating light and dark band is what causes that striation. But for cardiac muscle, it's not that way. Cardiac muscle is because if this is one cardiomyocyte, so yes, now skeletal muscle, the muscular is not striated. Which of them are you talking about? There are three muscle tissues. We have the skeletal, we have the smooth, and we have the cardiac. All right. Yeah. So for the cardiac, this is one cardiomyocyte, this is another cardiomyocyte. They join. You understand? So this line here that they join is what we call what? The disc. You understand? This disc. So this thing causes what? The striation. To consistent stretch. I don't get it very well. Maybe you shed more light on what you're saying. Okay, so but the structures you need to know is the cardiomyocyte, the intercalated disc, and also the electrical junctions. Electrical junctions are the gap junctions, right, where ions flow in and out. All right. Okay, got it. Perfect. So this is intercalated discs. This is intercalated disc. See the striations. Okay, guys. So let's move so that we don't waste too much time. So this is just talking about, this slide is just talking about the how the metabolism of the cardiac muscle, right? Very, very important that you know that, because the cardiac muscle depends exclusively on aerobic respiration. I've already discussed this, right? Aerobic respiration. It has a lot of glycogen, myoglobin, all right? Huge mitochondria. You understand? It's adaptable to different organic fuels. It can convert anything to fuel. You understand? It can convert fatty acid, glucose, ketones, lactate, and amino acids. So its fuel does not come only from glycogen. Glycogen breakdown is, glycogenolysis, right? That's how the body breaks down glycogen to get oxygen. Like me now, for example, I'm not eating trout today. Nothing. The only thing I've taken is this water. You understand? Now, I know that my body is already, that's why, I told you that test I did, they saw ketone in my urine. I laughed. I said, yes, because I'm not eating since yesterday. Now, so it's normal. Now, since I've not eaten, how do I have energy to talk to you? Trust me, I can talk for the next 10 hours. How do I have energy to talk to you? I have energy because my glycogen is being broken down through glycogenolysis, right? Back to glucose for me to be able to, then the oxygen I get reacts with it to form ATP for me. But if I don't eat till tomorrow, my glycogen storage will finish. So what does my body do? My body do what we call what? Gluconeogenesis. What is gluconeogenesis? Forming glucose from things that are not what? Glycogen. Like what? Like ketones. Do you understand? Like fatty acids, like lactates, like amino acids. So you now start breaking those things down, you understand, to form fuel for me. So, but the heart does it normally through glycogen, and the heart does it normally. It doesn't have to wait until the glycogen is exhausted. All right. Okay. So I've told you about when the heart goes into anaerobic. If it goes into anaerobic, it gets tired, and when it gets tired, it can die off. All right. Okay, guys. The heart works by itself. It pumps by itself. And what is that? The generator that pumps heart, that generates the electricity, the conedicine of the heart. I call it conedicine of the heart. Eh? Uh-huh. In your head, I wanted to say conedicine. What does conedicine do? Conedicine, I think I gave you this illustration in class. Conedicine helps to, power light in New York. So they are the SA node. So the SA node are the pacemakers. They are the ones that determine. They are the main wife. Don't know if I discussed this in class, but I think I did. They are the main wives. Please, did I discuss this in class? Because I want to jump. If you say yes now, I can move. Did I? I hope I'm not getting the classes confused. Yes or no? Have I discussed the conedicine of the heart? How the SA node works? No? Okay. Okay, perfect. That's okay. That's okay. No, okay. Perfect. Okay. It's okay. That's fine. So guys, pay attention. So, electricity of the heart is extremely important, right? See the heart out binging, 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 binging. What powers it? That electricity is generated by something we call what? SA node. I want you to know that SA node as the conedicine of the heart. Also know it as the first wife or the main wife. Just know it as the main wife. The main wife is everything. It's what that man wants. That's who he marries. That's who he saw everything in. Right? So that SA node is generating power for that guy. And the power is spreading. But according to the general consensus, men, the man, we still gotta have side chick out there. That side chick, I want you to know that side chick as what? AV node. You understand? AV node. When maybe he's angry, he fights with his wife or blah, 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 he goes to the AV node and the AV node steps him down, calms him down, say, oh, no, baby, it's okay. Don't fight with your wife, blah, blah, blah. Give him cold water and food. All right? So I want you to remember that SA node as that main wife that is in charge of the entire thing. But the AV node, his only function, side chick, his only function is just to step this guy down momentarily at some time when the functioning of the SA node is not at its optimum. Exactly. You say no way, Jesus. At its optimum. So we have the SA node, we have the AV node. The SA node, the AV node, the main wife, and the side chick. Think about it, guys. Perfect. Thank you for getting it. Think about it. The day that main wife say, you know what? I'm done. You have a side chick? I'm done. I'm angry. The day that she's so angry about the entire thing. She will shut down. Get out of my house. Get out of my house. What do you think the guy will do? First instinct, he will just go to the side chick's house. But unfortunately for him, the side chick is designed to entertain a lot of people, not only you. It's not only you. So she will just entertain you for a few days and be like, man, you need to go back to your wife, please. I really just like to be alone. You need to go back to your wife. Then the man will go back and start begging the wife. Think about it. When you think about it this way, when the AV node stops working, the SA node stops working, you depend on the AV node. Now, the SA node gives you your heartbeat around 60 to 100 beats per minute, right? Now, you depend on the AV node momentarily. The AV node holds you momentarily. And when that AV node holds you momentarily, your heartbeat will become what? Around 20 to 40 beats per minute. It will drop. Why? Because it's the AV node. And when that side chick is tired of you and say, you know what, get out, leave my house. That man, so if the wife still refuses, that man may have other little side chick, others, we call them others, extranodal, others. He will go to their places. Then his heartbeat will reduce to less than 20. If those others still throw him away, what do you think we do? his heartbeat will do time of death, so and so time. That's how it works. I need you to learn this sequence. You see how I moved from the SA node to the AV node, then to the other nodes. From SA node to the AV node, then to the other nodes. SA node will keep you from 60 to 100. AV node will keep you less than 60. Around 40, hovering around 40, momentarily. Then the other nodes, when the AV node is tired, the other node will take you around 20. When it's less than 20, the person dies off. You see, you see ECG now in the monitor. You guys work in the clinic. You see, but now that man, when he's in the AV node, he's still begging his first wife, his main wife, right? That's the SA node. That's when you see defibrillator. You guys know defibrillator now, right? Put it on the chest. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Do you understand? Then the main wife agrees, has already agreed now, right? When you defibrillate, the main wife will be like, you know what? Okay, I take you back. Then you see the heart rate. Do titin, 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 din, tin, 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 tin. Everybody in the world will be like, hey! That's how we shout. Actually, that's how we shout. We are so happy that somebody's alive. The life was saved. Do you understand? The life was saved. So what I need you to know now, you see how I mentioned this thing very playfully? I need you to remember it and know the sequence. I'll show you. Somebody's asking a question, Professor, if the AV node gives 20, what is condition of the patient? The patient, the heartbeat is already reduced. You understand? The patient is battling for his life. That's the truth. And it's usually at that moment, the patient is still breathing very low, breathing like the heart rate is still very low. If you check the ECG, you see tune. It will not be normal pim like you see like this. It will be boom, 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 boom. And if it gets lower, it's boom, 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 pim. Like this. That's how it works. So we now start defibrillating the patients. All right. When you defibrillate the patients, it's as if you are begging the SA node, please, can you come back? You are resetting everything. Please, I'm coming back. Let's start all over again. We are begging the SA node. And if the SA node agrees, the beats will pick up again. You see the ECG, it will pick up again, and the person will be normal, and all of us will be very happy. That's how it works. I need you to remember the story anytime, any day. Because the next things we are going to discuss, next few things we are going to discuss will be based around this story. So this is the SA node. Remember, the SA node is the pacemaker of the heart. It's the one that generates the electricity. Then in medical school, if I want to ask a girl out, I'll be like, hey, babe, what's up now? You look so pretty. Can you be my SA node? Yes, it will come back to sinus. Yeah, sinus rhythm is normal rhythm, right? Yeah, it will come back. Defibrillation helps to reset everything so that it will come back to sinus rhythm. But at that moment, the AV node is trying to hold that patient. The other nodes are also trying to hold that patient. You understand? So when you defibrillate, it comes back to sinus rhythm. So when it now comes back to sinus rhythm, the patient starts breathing normal. The beat is now normal. That's sinus rhythm. Then you are now looking for what caused that problem. You understand? You are trying to find what caused that pathology. So arrest it so that it doesn't happen again. All right? So what was I saying initially? What was I saying? Anyway, so we in medical school, we'll be like, oh, can you be my SA node? Do you get? Can you be my SA node? That's in medical school. Do you understand? Can you be my heartbeat? You know, that kind of thing. Then the girl will be like, no, I'm not going to be your SA node. I know you have an SA node. You just want to make me an AV node. That's casted. You know that that's casted. You know, you just leave that person and just start going your way because the person knows your story. Do you understand the point? I need you guys to get this concept. Play around these things. Joke with it. Henceforth, all of you be calling your partners SA node. You have to be romantic. You say, my SA node. Play with it. Joke around it. You get? If you leave me and go and look for an AV node or other nodes, I will shut you down. Right? That's how the ladies say it. Anyway, so let's continue. Nchebe, you play too much. Oh, Jesus. Anyway, so this is the AV node. I forgot to mention the location. The SA node is located in the sinoatrial region. Like that's why it's called sinoatrial node. You see that place that the blood enters the heart, the vena cava, the superior vena cava. You see that superior vena cava. That place it enters the heart, the right atrium. Under it, you see the SA node. Remember this. But the AV node, AV, atrioventricular, means it is around in between the atrium and the ventricle. Look at it. Located in the right atrium and ventricle, right near the right AV valve at the lower end of what? The interatrial septum. Now, from the AV node, you see the AV bundles of His, right? That is just branches of the AV node, branches like that. Then from there, you see other network. That is how the power flows. So the power will flow from SA node to AV to bundles of His to subendothelials. Look at it here. This is SA node. The SA node powers, boom, and it enters these two guys. That's the two atrium. But all of them will be taken by the AV node here and arranged. So the AV node helps to calm everything down because the power is too much energy, too much power. So the AV nodes will calm it down. You know, that's the importance of the AV nodes. I know somebody is laughing now and saying that I'm saying the importance of side cheek. I did not say the importance of side cheek. I say importance of AV node. Before you go and say something I didn't say. So this is a bundle of His, right? Then the bundle spreads to the subendothelial conducting network, all right? Each of them can be blocked, right? If this guy is blocked, then there's a problem. Okay, guys. Now let's talk about the nerve. All this while we've been talking about the artery, the vein. What about the nerves, guys? Yes, some patients have external pacemakers, of course. You understand? Those it's just like I didn't even mention stents. Stents is helps to keep the coronary patent. Now, pacemakers is helps to serve as an SA node for that patient. Yes, means that they have a problem. Yeah, that's why you must never fight anybody. Guys, did you guys I discussed with my students yesterday. Did you guys watch that video of a lady that pushed an old lady and she died? Just happened some days ago. The old lady was going through the walkway, what do you guys call this thing? The drive-through. So I think she had a problem. She decided to leave her car and come into the restaurant. She was talking to somebody. She and the little young girl, I think she was 22, they were having a little altercation, word altercation. So before you know it, they are too close to each other. Before you know it, I think one of them touched the old lady. The old lady now pushed this person on the face. Then the one in front just jumped on the old lady, pushed her to the floor. I don't know if it's mistakenly. I don't know if it's intentional. I can't say. But I'm just saying what I saw on the news. She stood up. The old lady stood up. And after that, they say she slumped and died. So now it becomes a trial, murder, and blah, 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 blah. You cannot go and be fighting somebody. I'm telling you, whether the person is old or young. First of all, that woman is old. I heard around 80-something years. So why you guys, I'm not being judgmental here, but why do you have to even fight her? You see, why? Even if it's somebody that is young like me now, you do something, I'll just laugh. Me that can laugh. I'll laugh the hell out of you. I can just keep laughing at you and you'll be wondering, why is this boy laughing? Do you get? I can laugh. Ask my mom. My mom will tell you that when I was born, I'm always laughing. Even when I'm crying, if you look at me like this, I'll start laughing with tears. I can laugh somebody. Why will I go and fight somebody? You don't know if the person has you just mentioned a pacemaker. You now hit the person on the chest. Pacemaker now shunt. Person have a pacemaker. You kill somebody's wife. That's what it means because that pacemaker is the wife. You understand? And no one, the person has cardiac arrest and die. And you just go to this thing. So please, guys, no matter what, no matter the provocation, because I don't think they let people go off based on provocation in this country. I really don't know a lot of laws in the United States, but they won't let you off based on provocation. all right? And just don't do it. Just avoid, oh, this one, okay, fine, bye. Simple, life goes on. Okay, that's by the way. Let's talk about the nerve supply, the innovation. Oh boy, we spent almost an hour, 30 minutes, and I really want to finish up very fast. Okay. Oh boy. So let's talk about the innovation. All right. I don't know if some of you were in my EP1 class when I taught the neuro, but you need to understand the neuro for you to be able to understand what we are talking about here. All right. Extremely important. Sympathetic nervous system increases the heart rate and contraction strength. That's why when you are running, you are in sympathetic. The heart rate has to increase because it has to give you more blood. Fight or flight, exactly. That's sympathetic. You understand? And that's sympathetic for the heart, you know, it for the particularly for the heart, it originates in the lower cervical, right? To the upper thoracic segments of the spinal cord. So it originates in the spinal cord, right? Then from the spinal cord, it goes up, something we call the sympathetic chain ganglia. Then it moves to the cervical ganglia. You know what ganglia is? Ganglia is that lump, all right, of nerves. So from the it forms from the lower cervical, right, to the thoracic segments of the spinal cord. Then from there, it moves to the sympathetic chain ganglia. From there, it ascends to the cervical ganglia, right? Now, there's something we call postganglionic fibers, right? These postganglionic fibers of that sympathetic pathway now goes to the cardiac plexus, and continues as what? Cardiac nerves to the heart. This is how it comes. Mind you, we are talking about sympathetic. Now, that fiber enters the heart. Where does it go to? It goes to the SA node and goes to the what? AV node. It goes to the SA node and goes to what? The AV node most times. So that's sympathetic. Now, when you talk about parasympathetic are the ones that slows down the heart, right? So they usually begin in the vagus nerve, which is found, has an origin in the medulla oblongata, right? So from that medulla oblongata, if you remember the brainstem, how the brainstem is arranged, we have the medulla, we have the pons, we have the midbrain. And the medulla is the lowest part of the brainstem. It gives off some cranial nerves, right? One of the cranial nerves is the vagus nerve. So this vagus nerve is extended to that cardiac plexus that we discussed for the sympathetic. This is the cardiac plexus. Where this is cardiac plexus, the postganglionic fiber. So this guy from the medulla oblongata. So you need to know where it originates from, medulla oblongata. This guy where it originates from the spinal cord. All right. So the parasympathetic enters the cardiac plexus and continues to the heart by way of the cardiac nerves. All right. So fibers of the right vagus nerve goes to the SA node. Fibers of the left vagus nerve goes to the AV node. You understand? So these are what you need to understand. And these guys steps down the heart. They steps out other places like the smooth muscle. You understand? Parasympathetic steps up other places. You understand? But sympathetic, for the heart, parasympathetic steps it down completely. Help me out in the final. Oh, you took your final today. Oh, congratulations. Thank you. I appreciate. Keep in touch, because I need you guys to help me test that new website we are bringing out next month. So please try to keep in touch. If you don't have my email, look for it. It's somewhere there. Or my number. You can even text me. No problem. Because I want to compile the list of the people that are going to test my system for me. All right. Right. Thank you so much. All right. Take care of yourself. I appreciate. Okay. So we are actually in 160. So this is 160 in case of if you want to be 160. Okay, guys. So now let's talk about. So we've discussed the sympathetic and parasympathetic. Let's talk about the electrical and contraction of the heart. You're welcome. The contraction of the heart. All right. So now there are two major events in the heart. We have the systole and the diastole. Guys, think. Look up. Stop looking at your book. I want you to look up. Look at me. The heart is a circle. You understand? This happens, this happens, this happens again, this happens, this happens again, this happens, this happens again, this happens. I'm not dancing. Now we have systole and we have diastole. Systole is when there is squeezing, contraction. Squeeze, systole, squeeze, systole. Remember, if systole is squeezed, that means the power will be higher, correct? Yes. That's why when you do your blood pressure, right? The one above, that number above is always higher. And that number above is the systole. Systole. Squeezing. That's the pressure your heart is squeezing against. You feel me? That's why that pressure is like 190. Your heart is actually squeezing against 190 millimeter mercury. You see? Which is a problem. That's why we say hypertensive emergency or urgency, rather. Squeezing against it. Things can burst. You get it? Now we have diastole, relaxation. Oh, diastole, relax. Calm down. Calm yourself down. Diastole, die. Oh, somebody has died. It's relaxing. Okay. Think about it that way. And diastole, die is the number below in blood pressure. So what have we discussed now? Systole, diastole. You can't forget this. But guys, you need to ask me, what is being contracted and what is being relaxed? Guys, we are only specifically talking about the ventricle, not the atrium. Forget about the atrium right now. The ventricle determines the systole and the diastole. The ventricle. All right. So we discussed the normal sinus reading, 70 to 80, sometimes between 70 to 100. Then there's something called ectopic focus, right? That's spontaneous firing from other SA node. You understand? May govern heart rhythm if SA node is damaged. Then we have nodal rhythm. If SA node is damaged, that's the first wife. The side chick takes over. That's the AV node. AV node beats around 40 to 50 BPM. All right. If the side chick say, you know what, leave my house. There's other ectopic focal rhythms that can take over. Right? Below 40. You understand? But they are too slow to sustain life. You cannot sustain. It's not sustainable. All right? Not sustainable. Okay, guys. So let's use this to understand this thing very well. Okay. Okay. So guys, this is how the potential works. Resting membrane potential. Resting membrane potential is when you are talking about, the potential inside the cell, the cardiomyocytes, the heart cells. All right. Now, it usually starts around minus 60 MV and drifts upwards. Why does it drift upwards? It drifts upwards because of a positive ion is entering inside. Just like in the skeletal muscle, when you guys do skeletal muscle, sodium jumps in. You understand? Sodium leads to what? Depolarization. Pacemaker potential. Guys, here we are talking about the pacemaker. You understand? How does the pacemaker fire? It starts usually minus 60 MV. Sodium jumps in, it depolarizes. When it reaches a threshold, the threshold is minus 40 MV. All right? That's threshold from minus 60 to minus 40. Mind you, minus 60 to minus 40. Minus 40 is more positive than minus 60. Why? Because of sodium entering inside. So remember, sodium influx starts the entire pacemaker potential. So when it reaches minus 40, what happens? There is fast calcium and fast sodium channels. They open up. Mind you, from minus 60 to minus 40 is slow sodium. When it gets to minus 40, it becomes fast sodium and fast what? Calcium. They jump in. And when they jump in, the thing moves immediately from minus 40 to what? 0. Fast depolarization. Fast depolarization. And when it's going up, what happens? Suddenly, potassium channels open. And remember, inside the cell, the major intracellular cation. Okay, let me ask it as a question. Guys, what is the major intracellular cation? Intracellular cation. I'm listening, guys. What's the major intracellular cation? Repeat. The major intracellular cation. Of which, what is the major positive ion inside a cell. Okay, guys, I'll tell you. Let me not waste your time. I'll tell you. Yeah, potassium. Hey, yes, somebody got it. Potassium. Of course, potassium. So potassium is the major intracellular cation. Sodium is the major extracellular cation. Another extracellular cation is calcium. So guys, think about it. That's why I told you sodium enters cell, but potassium leaves the cell. Wisdom, wisdom. Hit your head and say wisdom, wisdom, wisdom. So potassium is inside the cell. So if you bring a heart cell, potassium is inside. So for contraction to happen, for pacemaker potential to be formed, sodium, the cell opens. Even as potassium is inside the cell is still negative 60. Now, sodium is outside. Sodium will start entering. When sodium starts entering, the cell will start becoming what? Positive. That's why it moves from minus 60 to minus what? 40. That's being positive. When it gets to minus 40, that's low sodium. When it gets to minus 40, immediately the fast sodium and the fast calcium, right? We open, their channels will open and start jumping inside the cell very fast. So immediately it will jump from minus 40 to 0. That's being positive. That's depolarization. Now, when it gets to that point, what happens? The cell wants to go back to negative 60 again. How does the cell go back to negative 60? The potassium channel will open and potassium will start going out of the cell. And potassium is positive, right? So if it's going out of the cell will start becoming more negative and start going back to negative what? 0. So that is where the pacemaker potential is formed. Remember, how is contraction formed in skeletal muscle? Do you guys remember how contraction is formed in skeletal muscle? If you can remember very well, you see, the nerve bring the action potential to the synaptic terminal, right? That's the synaptic knob. In the synaptic knob, when action potential comes there, it leads to opening of calcium channel. Calcium will enter inside the synaptic knob, and that calcium will burst all the acetylcholine vesicles, all the vesicles there. When it bursts the vesicles, it will pour the vesicles into the synaptic cleft. Then the synaptic cleft, the acetylcholine in the synaptic cleft will go to the post-synaptic what? That's the muscle membrane. You understand? It will go to it and lap to the receptor. And once it laps to the receptor in the muscle, what happens? Sodium channel will open and rush into the muscle cell. The muscle becomes negative and depolarizes. Potassium opens up and jumps out. The muscle becomes negative and repolarizes. Sodium jumps in again. The muscles become positive and depolarizes. Potassium jumps out. Muscle becomes negative and depolarizes. So it keeps going up and down in the muscle cell. That's the postsynaptic cell. Up and down, up and down. And immediately keep going up and down. Action potential will be formed on that muscle. When action potential forms on that muscle, the action potential will now enter in through the T-tubule. If you remember very well, you discussed T-tubule. T-tubule is the at the middle of the two cisterns. The cisterns are the sarcoplasmic reticulum that carries calcium in the muscle. So the action potential will enter into the T-tubule. As it's entering, it's pushing the calcium away from the end part of the sarcoplasmic reticulum. Where does the calcium go to? The calcium will now go, right, and lap on the door handle, which is what? The troponin. To lap on troponin. And remember, troponin is actually on the tropomyosin. The tropomyosin is the door. So the handle is the troponin. Calcium will hold the handle, squeeze the handle, and open the troponin. That troponin, when that troponin opens, troponin is actually covering the active site of actin. So if it pulls, troponin pulls the tropomyosin, the active site of actin will become open. Then the myosin will lap on it and lead to what? Contraction. This is contraction in skeletal muscle. But here we are talking about the cardiac muscle. For contraction to even happen, we divided into the pacemaker. First of all, we are discussing about the pacemaker. That's the SA node. And I'm telling you that how the SA node works is that suddenly slow calcium will jump in, move it from minus 60 to minus 40. Then, because it's outside, then fast calcium will also start entering inside with fast sodium also enter inside and form it to 0. They become positive. Then the cell needs to go back to negative. Then potassium will start going out. So as it's doing like that, the SA node will become activated and give off energy. Boom! give off electricity. Boom. That's how it happens. You understand? That it will fire immediately. Piam! After every 8 seconds, 0.8 seconds, it will fire. Pium! Every 0.8 seconds, it fire. Pium! 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 So what happens between that 0.8 seconds is exactly what we have here. Sodium, slow sodium entering, then fast sodium and calcium entering, potassium coming out, just like that, up and down, up and down. Depolarization, repolarization, depolarization, repolarization, depolarization, repolarization. Then it pushes out power. Boom! So this is how it generates its power, the pacemaker. Is somebody confused? Okay. I believe you guys are with me. I have 15 people here. Oh. So this is exactly what we have here. Slow calcium, push it to here. Fast calcium and slow sodium, push it to here. Fast sodium and fast calcium, push it upwards. Potassium start going out, outflow comes down here. And the same thing keep happening. This is the pacemaker potential. This is where the action potential is formed. This is the threshold. Pium, this is action potential. Pium, 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 pium. Action potential is formed. So this action potential is that's power. It pushes out every 0.8 seconds. Boom. Okay. So once it pushes it out, signal from the SA nodes stimulate the atrium. The atria contracts immediately. If it pushes out, boom, the atria contracts immediately. Now it reaches the AV node in 50 seconds. Signals the AV node. The AV node signals slows down through the AV node. So everything slows down. Do you understand? Delays signal 100 ms, which allows the ventricles time to fill up. So, you know, these are rhythmics, but I just need you guys to understand the architecture of the entire thing in your head. You understand? Okay. Then this is how the signal spreads to the AV bundles and to every part of the heart. All right? Now, let's talk about the myocardium itself. We just discussed the pacemaker, right? Now, let's talk about the heart muscle itself. The heart muscle also contracts and expands when it is, you know, it receives that power. How does it contract and expand? Now, unlike the pacemaker, its resting potential is minus 60 in case of if you're asking the exam. The pacemaker potential is minus resting potential. Look at it. Let me go back so that you understand what I'm saying. Minus 60. That's the resting potential, minus 60. Now, but the heart cell, the resting potential is what? Minus 90 MV. Drink water, drink water. It's okay. You can drink water. Ah. Drink water, drink water. Do like this, guys. Because I can feel somebody's feeling sleepy. Somebody's smelling sleep. Better wake up. Okay. So, we've talked about the pacemaker. Let's talk about the heart muscle. Yeah. So, the heart muscle itself, its resting potential is minus 90 MV. Guys, it's negative, very negative, right? Now, there are three phases to the cardiomyocyte action potential. The question is, how does cardiomyocyte contract? That's what we mean. It produces an action potential, right? How does it produce action potential? Because normally everything is at rest, like this, minus 90. How does it get stimulated? First, three phases. Depolarization, plateau, and repolarization. Pium, pium, pium. You see? Depolarization, plateau, repolarization. You must know which is which. Why you need to know this is so that when you are discussing medications, yeah, so it doesn't rest. It really doesn't rest. But there's something we call resting membrane potential. You understand? So at every time it goes up and down. That's why you hear loop dup. Loop dup. So that's dup. It's as if it's resting. Loop dup. But we are coming to that. You understand? But the heart beats continuously. So, but this is the sequence of its beating, right? I've shown you the sequence, how the generation happens. Power happens every 0.8 seconds. Now, this is for the muscle of the heart itself, how it responds to that power that is generated and produces its own power. All right? That's its action potential. So for here, it has depolarization, plateau, and repolarization. But the pacemaker has which one? Depolarization and repolarization. Depolarization and repolarization. But this guy has what? The muscles has what? 3. Look at the diagram. See? Pium, depolarization. Plateau, repolarization. You see it? Pium, depolarization. Plateau, repolarization. So I need you guys to understand that. If you know it in your head, you are good to go. Perfect, 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 perfect. So if I ask you RMP, that's resting membrane potential for myocardium, tell me 90 minus 90 MV. If I tell you RMP for pacemaker, tell me minus 60 MV. All right? Phases in pacemaker 2, depolarization, repolarization. Phases in myocardium 3, depolarization, plateau, repolarization. This is the comparison you need to make in your head right now. All right? So depolarization is for this guy is very brief. Unlike the plateau, unlike the pacemaker. Look at the pacemaker. See? It's slow. Bam, bam. You see? Bam, bam. All this is repolarization. Depolarization, rather. Bam, bam. So this is slow calcium. Sorry, slow sodium. Fast sodium and fast calcium. Bam. So there are 3 things you need to know here. This guy, slow, gets from 60 to minus 40. Fast calcium and fast sodium, take it to 0. Potassium start going out, it comes down again. This guy repeats itself again, just like that. Action potential is produced. Pacemaker. But the muscle, what happens? Depolarization is very fast. That stimulus that is coming from that guy, that action potential coming from the pacemaker, once it gets to the heart muscles, what does it do? It causes what? Opening of what? Sodium gates. Sodium rushing. And immediately sodium rushing. Sodium takes it immediately to plus 30 MV. So let me show you. You see? Look at it here, guys. So if I give you this diagram and tell you what is 1, you automatically tell me that this 1, you understand, is when the sodium channel is open. You know? This is minus 80. So this place is definitely minus 90. So this is RMP, resting membrane potential. Not RIPO, not rest in peace. Hey, God, not rest in peace. So somebody told me RIP about my father, some days ago. The burial for my dad is on 5th of next month. I told you guys I lost my dad, right? Yes, I think I did. I lost him 2 months ago. So, but the burial is next month. Okay, guys, I just remembered because of this RIP I just said now. So, so this is, yeah, thank you. Thank you. Thank you so much. I appreciate it, guys. Yeah. So, yeah, thank you so much. So this is the RMP, resting membrane potential at minus 90. Immediately, calcium channels open here. But the calcium is so fast. Fast calcium. It doesn't even have time to do slow calcium there. Fast calcium. So if somebody asks you what is 2, you tell the 2 that it's fast inflow of calcium. You understand? And when calcium open, it triggers more calcium, So you just do like the depolarization is so fast. And calcium stops here. Bam. Let me go back. Depolarization stops. Plus 30. Very fast. From minus 70 to plus 30. You see how fast it is? You guys need to appreciate this thing, guys. Yeah. Now, it's plateaus. This is plateau phase, which lasts 200 to 250 microseconds. Sustains contraction for expulsion of blood from the heart. Sustains contraction for expulsion of blood from the heart. What happens in this plateau phase? That's what you really need to know. Slow calcium comes in. So voltage-gated slow calciums open, pushing and admitting calcium into the cells. Now, the calcium binds to troponin, triggering what? Contraction. That is plateau phase. It is slow. It is entering the cell. It is slow. Do you understand? But what is it really doing? It's opening the calcium channels on the sarcoplasmic reticulum. Sarcoplasmic reticulum is usually where calcium is being stored. So when these channels open, this slow calcium opens these channels. These channels, what do they do? the sodium from the calcium from it comes out and goes and laps on the troponin, triggering contraction, which is exactly what I described initially. Troponin opens the contract for the skeletal muscle. It opens the tropomyosin, which is the door. I've described it before as the door. If you watch my videos, I described tropomyosin as the door. I described troponin as the handle. So the troponin, thank you so much, opens the door. And the door, what is it covering? It's covering the active site of actin. Calcium holds onto that troponin. You're welcome. Thank you so much. So here, what the slow calcium do is to open the channel calcium channels on the sarcoplasmic reticulum. If you open it, calcium jumps out and triggers troponin to cause what? Contraction. That's the phase. All right. Then at that moment, repolarization phase occurs. Calcium channels close. Potassium channels open. Rapid diffusion of potassium out of the cell. The thing will start getting back to negative. So let me show you. Look at the diagram, guys. So we stopped at number 3. So at this number 3 is where the sodium channel closes. That's the peak. Sodium channel closes here. Sodium enters, sodium channel closes. Then number 4 is the plateau state. So calcium entering through slow calcium channels, prolonged depolarization. It just holds this depolarization for some time. It's just like you are holding on something. Your hand is getting weaker. You are dropping it a little. That's exactly what's happening. That's what happens in plateau phase. So calcium is just holding the depolarization slightly. Do you understand? But does it continue holding it? No. It cannot continue holding it. Why? Because potassium starts going out of the cell. And when potassium starts going out of the cell, it will repolarize. It falls down because everything goes back to negativity. Because potassium, which is positive ion inside the cell, is going out rapidly. And calcium has closed. So if they ask you for myocardium, sodium is what causes depolarization. This plateau state is caused by what? Calcium. This repolarization state is what is caused by what? Potassium going out of the cell and calcium close. Calcium closing. The calcium channel closing and potassium going out of the cell. That's what causes repolarization. But what causes plateau is calcium. What causes depolarization is sodium. So I need you guys to take your time and look at this. Use this thing to do your wallpaper. Remove his picture from your status. Use this one. From your wallpaper, use this one as his picture. You understand? You say? No. What closes at 3 is sodium. Look at it. Sodium goes up. Sodium closes here. And you know, immediately sodium closes, this thing is supposed to fall. But calcium starts holding it. You understand? That's calcium holds it here. You understand? Then when calcium closes and potassium starts going out, it falls finally. Why are they laughing? What have I said again? Sometimes I don't even remember what I say. It just comes out of my mouth. Okay. Yeah, I really don't use these diagrams. So I'm going to remove it from this slide, actually. So we know electrocardiogram. Everybody know ECG or EKG. You understand? We use it to check the action potentials of the heart to dictate different things. Electricity of the heart. What is happening? Exactly. So this ECG, you understand? You are not expected to just know ECG so much, but you need to know at least the different parts of ECG. You need to look at ECG and then, oh, this is a normal ECG. Do you understand? If you look at it very well, you understand what we are talking about. So this is a prototype. You know, the other one is your wallpaper. This one is your screensaver. Remove that picture you have, his picture you have there, or her picture you have there. Use this as your wallpaper, please, until you write this exam next week. Then you can now put it back. And hide your phone so that he doesn't see it because you think you don't like him anymore. And you put it on my head, please. Oh. I don't used to spoil relationships. Anyway, that's by the way. So if you look at this ECG here, we highlighted this guy here to be here, right? This thing happens in 0.8 seconds. I told you, firing 0.8 seconds. It starts again. See? So this is the P wave. You see, this is P wave. This is T wave. All right. This is the QRS complex. This is the PR interval. This is Q. This is Q, T interval. All right? It's PR interval. So this is an interval, this interval. All right? We also have the QRS interval here. Why do you need to know these things? Because you are seeing the normal here. You understand? This firing of 0.8 seconds sets the heart at 75 BPM. If it fires too fast, this thing goes up. Fires too slow, this thing goes down. All right? So this is normal. What did I tell you initially about physiology? You need to know the normal. So that when you see an ECG that is not normal, you will know. As if you're in medical school, your part of your exam is that they'll bring like 30 ECGs and keep for you and tell you to make diagnosis. That's medical school for you. But here, you are just learning the superficial anatomy, which is okay. All right? Aha. Okay, so and also you need to know the corresponding things. Like this PR interval corresponds to the atrial contraction. Anything PR here, this thing is atrium. This is atrium. Why this is ventricle? So this atrial contraction, this is ventricular contraction. PR, atrial contraction. P, atrial. QR, anything QRS, talk about ventricle. That's why it's even bigger. All right. So if you see a problem here, know that the ventricle is having issues. If you see a problem here, know that the atrium is having issues. All right. That's how you are able to understand ECG properly. So this is everything you need to know. You look it up later, right? If there's a problem, if there's a problem in any of them, it can cause a lot of issues. And you need to know what these things are. Like the P wave in your exam, they can tell you what is P wave. Tell them that P wave is atrial or depolarization. They can tell you what is QRS complex. And sure, that's the kind of question you see. Trust me. What is QRS complex? You see, like later, just go and look the videos. Look at all the reviews I've done for this topic. I even posted one for you last night. If you see the time I posted it, somebody sent me a message. Say, Professor, don't you sleep? I sleep. I actually sleep. You understand? Just that usually those nights are usually time that I'm extremely comfortable to do whatever I want to do. So this is P wave. QRS. You need to know P wave is atrial depolarization. You need to know that QRS is ventricular depolarization. In your question, it will tell you QRS complex represents what? You tell us ventricular depolarization. And trust me, the option A will be atrial depolarization. Don't pick it. They are just trying to lure you. And please, I don't want you to learn this in such a way that you come to exam hall, you say, which one is atrial depolarization again? No, is it P wave or is it QRS complex? No. QRS is large in the ear. Ventricle is large. So just put it that way. You understand? Put it that way. All right? Why T wave signifies ventricular depolarization and relaxation. But ventricular depolarization and contraction is QRS. All right? AC segment is just ventricular systole. We'll discuss about this. This is where the myocardial action potential comes into existence. So this is another diagram that I need you to study very well because it corresponds to each arm of the ECG. All right? Take your time to look at it. Now, what are some abnormal readings that you can get in an ECG? Trust me, I told you, you need to know the normal. What are some of the abnormal what can an ECG tell you? That's why it's always good for you to go to the hospital and check. See me that is talking. I've not checked since I came here. And I'm busy advising. I don't know. Is it true? They said, is it true that doctors and nurses makes the worst patients? What's your opinion, guys? Yes? If you see where I'm advising somebody, go and check your heart. Go and do the lipid panel. You need it. You need it. So that you know where you stand. So that you can do pap smear. Go and do this one. Go and do that one. Advisor of the universe. Exactly. Who self-diagnose. That's how somebody I used to know. Oh, I know. Oh, maybe it depends on the person. I know somebody, he had a bump here. A boil, we call it boil. here at the back of the head. He was my classmate. This boy refused to come to school. Why is this thing looking so big? Hold on. So he had a bump in the back of the head here. He refused to come to school. 1 week, this boy did not come to school. Then later, when we the same hostel, he locked himself in the room. I'm telling you, I thought he was not even around. I thought he traveled in the hostel. That was medical school. So when I said, bro, what's up? What happened? He said, Nchebe, I thought I had HIV. I was shocked. I said, how did you diagnose yourself of HIV? He said, because HIV, one of the symptoms is you have Kaposi sarcoma. You know what Kaposi sarcoma is, guys? You should go look it up. Kaposi sarcoma. And he was thinking, Jesus Christ. I said, a normal person, we have that boy, and we just go and take an ampiclox, and the person will be fine. But you, because you're a medical student, as of then, we're a medical student, you start overthinking it. And because of that, you now be self-diagnosing nonsense. And you now be in your room. Anyway, that's by the way, guys. So let's go. What are the deviations of ECG from a normal, right? It can indicate myocardial infarction, right? Sudden block of coronary artery, abnormalities in the conducting pathway. It can even show that heart is enlarged. You understand? Or electrolyte or hormonal imbalances. All these things, you can see it on an ECG. You can't see it on an ECG. Look at the normal ECG. This is the normal sinus reading. Look at ventricular fibrillation. Do you see? This person is dying. This person most likely is going to have a cardiac arrest if care is not taken. Right? This is ventricular fibrillation. You understand the point? So, how do you know that this is wrong? This is a problem. Because you look at this one and you know that this is normal. This is what we are saying. This is physiology. This is pathology. You look at the physiology. So you need to get yourself properly acquainted with this particular physiology so that when they give you this thing in the lab or in the clinic, you look at it, you say, nah, something is wrong. This thing is just going free wave. This has to be ventricular fibrillation. Do you understand? Yeah, exactly. It does have a QRS complex. This is a QRS complex, but it's not showing properly. You understand? It's not like the normal QRS complex. You can't even differentiate the QRS complex. You can't differentiate the T waves. You can't differentiate the P waves. All right, but that's by the way. So this fibrillation explained, right? There's a lot of things about it. You can look it up very later. It kills very quick, as I told you. Kills quickly if not stopped. You understand? And what do? We shock that person. Shock the hell out of that person. And as I remember somebody asked me before, if you shock the person, will the person be normal? Yes, it will come back to normal, but you need to look for the problem because that shocking is not problem. It's not solving the problem. It's just trying to keep that person there for now. You understand? So it's usually hallmark. Ventricular fibrillation is hallmark of myocardial infarction. So if you do this thing in the clinic and you see, Jesus, this is a VFib. We call it VFib. We have AFib and VFib. We have atrial fibrillation and one ventricular fibrillation. Yeah, this is AFib. This is VFib. This person may have myocardial infarction. You see everybody run up and down. All right? Okay. Anyway, that's by the way. I'm not here to teach that pathology. This is heart block, right? This is heart block. And what do you notice about heart block? You see, it forms P before it forms another complex. Compare this heart block to this normal. You see, this P, all right? This P forms P. You understand? See, this forms another P, forms another P, forms another P. But look at this guy here. You understand? It keeps forming P without forming even an QRS complex. Then you know that this is heart block. So if you look at this, that's why you need to know the normal. It's just all about identification. You understand? There are formulas to this thing, but I'm not teaching ECG here right now. So, but this, if you look at this, you say, oh, this person has a heart block. You look at this one, this is premature ventricular contraction. You understand? The normal, this one now decides to go down and it's continue normal again. Then after a while, this guy goes down again. Do you understand? The QRS complex, instead of being upwards, it's inverts. All right, you say, oh, this person have premature ventricular contraction. So there are a whole lot of them. right? But that's what you do in pathology class. So I'm jumping now to flow, the cardiac cycle. You see how fast we are? Truth about that is that when I teach online, it's always very fast because I am the only one that can interrupt myself. you know, and we're already in this thing. Very soon now we are done. And we're just spending how many hours? 2 hours, 20 minutes. We will be done before 3 hours. But it's not about being done. It's just all about getting it. All right. I need you guys to catch this thing so that when you now watch those questions, you'll be able to be answering it quickly. Like when I even say a question, you pause and you answer. You understand? Steez. You have to show steez when you're preparing for this exam. Write it with confirm. You understand? Okay. Okay. So let's talk about the blood flow, heart sounds, and cardiac cycle. Cardiac cycle, one complete contraction and relaxation of all 4 chambers of the heart. Cardiac cycle, complete contraction and relaxation of all 4 chambers of the heart. Remember that, all right? So we want to discuss a whole lot of things. There are principles that govern it, all right? 2 main variables govern fluid movement. Pressure causes flow and resistance opposes it. Assuming we are in the class now, I could have brought somebody out now, and I'll push the person slightly. That's pressure, right? If I push you slightly, what will happen? You will move forward. But if you are going forward and somebody is blocking you, can you go forward? No. So that's pressure and resistance. Pressure encourages, resistance opposes. If the pressure is higher than the pressure at the back is higher than the pressure at the front, what will happen? That pressure at the back will push the fluid to keep what? Going forward. Arts? Are they arts? I don't know about arts. So let me see if there's any way I can remove the art. It's YouTube people self. Not for me. Why are they arts? Oh, I don't know how to remove it. Honestly, I would have wanted to remove it. I really don't know how to remove it. Maybe I'll check it later and see a way to be removing the art so that you guys can be free to watch your thing. You don't have ads. Okay. I really don't know how these things work. Me, I'm not a Gen Z now. Okay, guys. So these are the 2 variables, right? Fluid will only flow if there is a pressure gradient. If there is no pressure, what happens to that fluid? The fluid will remain at one place. If there's no pressure. But if there's pressure, the fluid will go. If there's opposition, the fluid will stop. How do we measure that pressure that forces the fluid to go? We measure it in millimeter mercury. You understand? In millimeter mercury. I'm so sorry about that. I don't know how those things work. In millimeter mercury. But don't worry about yourself. The video is always there, so you can always go back to it, all right? It's permanent there. So pressure is measured in millimeter mercury with a manometer, right? That manometer, we call it what? In the clinic, we call it what? Sphygmomanometer. Initially, I call this thing, you see this place now? You see this place? I call it sphygno. I always put N here. So, but the right pronunciation is sphygmomanometer. In the clinic, there are a lot of nurses and doctors that don't even know this pronunciation. Trust me. Ask them the name. They say, see, that is fig. It's fig. I know it's fig. Call it the complete name. Call it the complete name. All right. So it's sphygmomanometer. All right. Aha. Okay. Let's proceed. So this is just talking about the principles of flow. All right. If you look at here, we already discussed the principles of flow. Something we continue moving forward if there's more pressure to it. All right. So let's divide the heart into 2. The left side and the right side. We already discussed this thing before, but just a recap. The left side, what happens in the left side? Ventricles relax and expands, right? When ventricle relax, the pressure drops. Think about it this way. This is when I need this thing. Is there any way I can pause this video to go and get water? I don't want you people to see me walking. Let me see if I can move with my seat. Just a minute. Let me see if I can move with my seat. No, let's leave it. I'll just explain it with my head. And you will understand. Don't worry. I know how to explain things very well. I know you laugh. You are starting laughing. I will never give you the I'll never give you that joy. I know. Jesus. So you guys can see my this. Let me remove it. Oh Jesus. Later I'll look at when they did this video and cut out that part. Very good. So guys, come back to me. Come back. I know you are busy laughing and enjoying yourself, but that's fine. So come back to me. Let's talk about this, all right? Extremely important that you understand this concept. Pay attention. Think of a way to explain it. See, what is up is what? The atrium, correct? What is below it is the ventricle, correct? In between the atrium and the ventricle, we have the AV valves, correct? This is ventricle. Below the ventricle, what do you have? You have another two valves. That's the semilunar valves. One leads to the pulmonary artery, one leads to the aorta. These valves work as sphincters. They close up and open up. All right? Now, let's in the left side of the heart, when the ventricle relaxes, like this, watch me. Relax. When you relax, what happens? You get bigger, correct? Boom. You understand? It tells you that the ventricle is filling up. Just the same thing with the right side, all right? So I need you guys to follow me. Just walk with me. When the ventricle relaxes, it starts filling up. Guys, think about it. If I want to pour water inside this thing now, so it's relaxed, right? It's filling up. If it's filling up, for this thing to ever fill up, it means that this below is covered, correct? Yes. So what does it tell you? It tells you that when the ventricle is relaxed and dilated, it is filling up from up, meaning that that valve up is open and the valves down is closed. Please, if you don't understand me, you have to speak up so that I will re-explain. Because this is something that you will hold all the days of your life, even in the clinic. When the ventricle, I told you that the subject is ventricle. Don't ever think about atrium. It's always ventricle. Controls everything. So the ventricle, when it relaxes, when something relaxes, watch me. Something that is closed now, for it to relax, it has to open, right? It open up. That up opening, what is this up? This up part is what? The valves, AV valves. And up here is the atrium. So blood enters the atrium, and this ventricle opens up, blood now enters. As blood is opening up, ventricle is expanded. But at that moment, this down here, that's the semilunar valves, is closed, it's shut closed. This semilunar valve is shut closed. Pressure inside the fluid, is inside the ventricle, is low because it's open, it's not squeezing, it's open. Pressure is low. And at that moment, how do we measure the pressure? We call it what? Diastole. That's relaxation. Ventricular relaxation is what? Diastole. If they ask you what events happen in diastole, you are telling them that in diastole, the AV valves are what? Open. But the semilunar valves are closed in diastole. The pressure is what? Low. What happens in systole? I'm trying to make you understand these things. What happens in systole? Guy, watch. Systole is squeezing. At that point, ventricle need to push out blood. How does ventricle gather that strength, that pressure to push out blood? It has to, for it to push out, it cannot be receiving and be pushing out at the same time. No. So for it to push out, it increases pressure. How does it increase pressure? It closes his hand. I need you all to hold your hand and squeeze your hand. Squeeze your hand. When you squeeze your hand, don't you see the power you are using? Stop being sexy with squeezing hands. Just squeeze it. Squeeze it. Don't be doing like I'm seeing somebody in my head doing squeeze it. So when you squeeze, power. But when you relax, low pressure. So when it's squeezing, that up valve, that's the AV valves in the two sides, are closed for it to be able to squeeze. And where is it squeezing out from? Squeezing out from the semilunar valves into the lungs and into the aorta at the same time. That is what we call what? Systole. And that pressure is what is up when you take somebody's BP. So in your clinic, if they ask you, what does, not even in clinic, in this exam, what does systole do? Or what happens in systole? You are telling me that systole, the AV valves are what? Closed. Why the semilunar valves are what? Open. Simple. Pressure is higher. But relaxation, no pressure. It's depicted on this diagram. So you look at it properly. Who has a question? If you have a question, you can ask. Okay. You get it. Remember, I told you that the valve is like this, right? So it opens, blood flows in. The AV valves, sometimes or others, blood flows in, it closes back, right? Pium, 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 pium. So even when this guy is squeezing, it's still closed like this. Squeezing is still closed. Imagine if when this guy squeezes, it opens like this. So the squeezing will be going down and up. That's what we call regurgitation. Anything that will make this valve incompetent, we call it valvular insufficiency or valvular incompetence. So it's a failure of the valve to prevent what? Regurgitation. Regurgitation is going backwards. What could cause this problem? It can be stenosis. Stenosis is, you see that cups I showed you, like tricuspid, 3 cups. When they become stiff, maybe the person have a rheumatic heart failure, rheumatic fever sometimes. Yes. Yes. So the valve should hold. You understand? Open, blood pours in, closes, open, blood pours in. So when that guy is squeezing, it should not what? Open. No. At that moment, it shouldn't open. So when it becomes stiff, it can easily what? Open when this guy is squeezing. That's what we call insufficiency. And what can make it stiff? It can be rheumatic fever, it can be autoimmune attack on the mitral and the you said it's mitral, right? On the mitral and the aortic valves. Do you understand? Or maybe when the heart is enlarged because it's overworking itself. You understand? Maybe someone that has hypertension. You understand? Over time, the heart will definitely enlarge many times. You understand? And what you start hearing what? Abnormal murmur. So instead of hearing loop dup, you'll be hearing loop dup, loop dup, loop dup, loop dup, loop dup, loop dup. So you're hearing the loop and the dope, but you're hearing a third heart sound, which is the heart sound of that regurg that you shouldn't be hearing. And you hear it, I'm hearing a third heart sound. This person definitely having incompetent valves. mitral valve can prolapse. Mitral valve is the one that has the highest prolapsing sequence, right? That's why we say mitral valve prolapse. You remember mitral valve? That's the bicuspid valve. It can prolapse a lot. You understand? Insufficiency in any of the cups, those three cups, two cups rather, insufficiency in any of them. It can be as a result of hereditary, 1 out of 40 people. Most times it causes chest pain and shortness of breath. You understand? Auscultation is when you listen to heart sound, right? So I mentioned we have the first heart sound, and this is something they will never fail to ask you in exam. You understand? No Jupiter. What happens in the first heart sound and what happens in the second heart sound? Guys, heart sound is as a result of closure of valve, not opening of valves. Fundamental basic knowledge. Closure of what? Valves. So, when the heart dilates like this, things enter. So, for the heart to dilate, the semilunar valve will close. Dope. So that semilunar valve, the second one, semilunar valve causes what? Second heart sound. Dope. Closure of semilunar valve. Dope. And when semilunar valve closes, the diastole begins. So second heart sound, diastole begins. When the diastole is done, this AV valve closes. Tom. That's first heart sound. Semilunar valves open. Squeezing happens. Systole happens. Squeeze out. So if they ask you in the exam, first heart sound is called what? Loop. Second heart sound is called what? Doop. What causes first heart sound? AV. First, AV. A for apple. What's my phone doing? Keep quiet now. So first, AV. All right. Second heart sound is what? Doop. Semilunar valves. Keep quiet. Sorry. This is my phone. It's always doing this thing. So sometimes in people over 30, you can hear third heart sound. Sometimes, it can just be as a result of one anomaly or not, or the other. So guys, there are 4 phases you need to know. Watch me. Watch my hand. Pium is filling. Pium, 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 pium. The ventricle, mind you, all this thing is ventricle. We do not mention atrium. Pium, ventricle is filling. This is called what? Ventricular filling. Happens as a result of what? Diastole. Second thing is that when the ventricle is filling, you understand, this guy is what? Relaxed. Both the two ventricles, so the left and right ventricle is equally. That's what we call what? Isovolumetric what? Relaxation. So isovolumetric relaxation and ventricular filling occurs at the same time in diastole. You can never, ever forget what I just said. It opens up. That's relaxation. Opens up here, relaxation. Isovolumetric relaxation, because it happens in the two ventricles at the same time. Now, this guy starts filling it up. Ventricular filling. Ventricular what? Say it. Ventricular what? Filling. Both of them happens as what? Diastole. After that, what happened? Pim, this guy starts squeezing. So that squeezing, you understand, contraction happens in the two sides. It becomes isovolumetric what? Contraction. Iso, the same volume pushing out. Isovolumetric what? Contraction happening. Where is it happening? In the systole. And what is happening? It's ejecting blood out of the heart. Blood is going out of the heart. The right is going to the lungs. The left is going to the system. Systemic circulation. Out of the heart, that's what? Ejection. So if they ask you about ejection, ventricular ejection, it happens in the systole. If they ask you ventricular isovolumetric contraction, it happens in the systole. If they ask you filling or relaxation, it happens in the diastole. Any question? No question. Okay. Perfecto. So what I just discussed here. Okay, no question. Perfect. So like this is ventricular filling, right? This is exactly what I've just discussed. AV valves open, blood flows into the ventricle. You understand? There's rapid filling, one third, diastasis, second, third, slower filling. It goes slowly, right? P wave occurs at the end of what? This diastasis. Diastasis is second and third filling, right? Second filling sometimes becomes very slow and it becomes slower, right? That's when P wave is formed, all right? So it's refill open, then P wave starts forming. You understand? P wave forms occurs at the end of diastasis, at the end of this guy. So when ventricular filling is completed, P wave happens. Now, end diastolic volume. I need you guys to understand something. End diastolic volume is achieved in each ventricle. When you say end diastolic volume is, guys, watch me. This is ventricle. Remember, everything we're talking about is ventricle. Ventricle will open up. Pew! Fluid is entering. When it fills up, that is what we call end diastolic volume. That volume inside, that amount of fluid inside those ventricles is known as what? End diastolic volume. Who has a problem? Who has a question? And if you see here EDV, just listen. I'm explaining this thing with common parlance, devoid of jargons, for you guys to understand the concept. If you know the concept, you will never forget. Let me tell you, I'm trying to explain this thing so that even somebody that's not an anatomy student will be able to understand what I'm saying. If I open this ventricle to fill, I open this water. Look at it now. I open this thing now. I pour water inside. It fills up. I close it. Assuming this is the ventricle, this volume of fluid inside it right now is the end diastolic volume. Whether there is water inside before, then this one fills it up, or as far as it's inside right now, after this filling, it's known as end diastolic volume. Somebody will ask me, what is end systolic volume? Okay, when it's finished, this guy will squeeze to open up here, open the semilunar valves and squeeze out, right? When it squeezes out, after squeezing, some fluid is still inside the ventricle. Then this semilunar valve covers up. The remaining fluid inside the ventricle, after it has finished squeezing, that systole, is what? End systolic volume. How about that fluid that it poured out? You understand? Let's say it poured out some fluid. How about that fluid it poured out? That fluid it poured out is called what? Stroke volume. How many things have I discussed now? 3. Again, it opens up, it fills up, end diastolic volume, 130 mils of blood. It opens up and presses out, inside this 130 mils, it presses out what? Maybe like presses out 60. Presses out what? 60. How many will remain inside? Guys, do the math quickly. How many will remain inside? When it presses out, we have already attained that the EDV is 130, right? So the amount of fluid inside this thing right now is 130. Now it opens up and presses out 60. How many is remaining? Is there only one person that we have here? I thought that 20 people or 10 people would just write the same answer for me. It presses out 60. How many will remain inside the fluid from the 130? It's okay, right? Anything you write, even if it's wrong, I'll correct you. You understand? But I need to be sure that everybody's here. 2 people. 1 person decided to change their mind. 3, 4. Perfect. You guys are active and engaged. That's what I just needed. Okay. So that 70 remaining is what? The end systolic volume. That 70 remaining is what? The end systolic volume. So how many? If they ask you, okay, so how many fluid left the container? What will you say? How many? Give me the number. 130 was in the container. That's end diastolic volume. I pressed out 60. Remaining what? 70. You guys say it's remaining 70. Yes. So that 70 is what? The end diastolic volume. And the one I pressed out is how many? 60. Perfect. That 60 is what? That 60 is the stroke volume. So if they tell you guys, if they tell you, hey, calculate the end diastolic volume. If they ask you to calculate end diastolic volume right now, if they say, what's the amount of fluid in this container? Use this container as an example. What's the amount of fluid in this this container? In this ventricle, you tell them, the amount of fluid in this ventricle is what? End diastolic volume. And I can calculate it with the amount of fluid remaining after I pressed it out and the amount of fluid I pressed out. So the ESV, you understand, ESV plus stroke volume will give you EDV. If you look down here, you see, look down here, you see ESV. ESV, how do you get ESV? ESV is the one that is remaining after you squeezed out, right? So for me to get ESV, if I want to know the number of ESV, if I know the amount in the container and the amount I squeezed out, I just remove the amount I squeezed out, right? The amount I squeezed out from the total amount in the container, and I'll get my ESV. Check it out. So guys, who is confused about EDV, ESV, and SV? Now, tell me. I get it. So let me hear from other people. Guys, talk. I need to hear from you quickly, guys. Quickly, we don't have much time. I really want to give you time to go study. Quickly, let me see. 2 people got it. Where are the others? Okay, you got it. Okay, guys, perfect. As you guys got, yeah, you could explain again if you like. No, I don't like explaining again, except if somebody didn't get it. But if you get it, we move. You understand? Yeah, it's making sense, but I always need to study more to really get it. I get it. I just need to review. But yeah, okay. You know what? Don't worry. We have time. We really have time. You understand? Because trust me, this class is supposed to be 5 hours, but I want to use 3 hours for you. But I have time. So I'm going to use probably 3 hours, 30 minutes. All right. And I will leave you to go and do your thing. So because of that, I will re-explain. I want you to understand it. You must understand it today. This is ventricle, correct? Up of the ventricle, this is atrium. He said, wait, I got the commercial. Let's wait after the commercial. Honestly, I didn't know that they do the adverts thing here. How come my other students never told me? Okay. So this is ventricle. This is the top of the ventricle. So here you have the AV valve, right? This is the atrium. This is the down of the ventricle, which is the semilunar valves, right? We're talking about the 2 ventricles, actually. So for this guy to fill up, this guy has to, semilunar valve will be closed, right? This guy, the AV valve will open up. That's diastole. That's ventricular isometric relaxation. That's diastole. What happens here? Sorry. What happens here? Fluid from here will fill. Once it fills it up, the valve here will shut close. Pakam. The AV valves. That's the first heart sound. Lop, to lock up. Lop. That fluid immediately, before this guy opens, the amount of fluid here inside this kettle now, inside this my cup now, is 130 mils. And that fluid is known as what? End diastolic volume. Why is it end diastolic volume? Remember, when it opens, it's diastole. When it closes, diastole has finished. So the end of diastole, the volume at the end of diastole is end diastolic volume. How to get EDV? That's what I'm telling you right now. The volume at the end of diastole, you measure that volume at the end of diastole. That is EDV. So I'm trying to make you understand it, so that because they can give you parameters in exam to tell you to calculate EDV. How do you calculate EDV? You first of all need to know what EDV is. If you know what EDV is, you will derive it. If they give you, they tell you, the stroke volume is this, the EDV is this, the stroke volume is this, the ESV is this. How do you get EDV? So look at the wisdom in it. So assume, I want you in your paper now, just assume that this EDV, at the end of everything, the volume inside this container that fills up this container is 130 mils. So you write down 130 mils. Now, immediately, this semilunar valve down here opens up. When it opens up, what happens to this guy? Systole. It will squeeze. Systole, remember systole, we say systole is what? Squeezing. So systole, it will squeeze because it's pushing out the fluid. That's 130 mil out. But at the end of the day, it can only push out 60 mils. So I want you to write end of squeezing 60 mils. You know, or rather, no, don't write end of squeezing 60 mils. It squeezed out 60 mils, right? Yes, high pressure. It squeezed out 60 mils, correct? What is the volume remaining at the end of the squeezing? That volume remaining is what we call what? End systolic volume. Squeezing, systolic. The volume remaining at the end of diastole is end diastolic. This perfect. So if it squeezes out 60, that means the end systolic volume is what? 70. If it squeezes out 70, that means the end systolic volume is 60. If it squeezes out 100, that means the end systolic volume is what? 30. Play with it. You get? Now the question is, that one is squeezed out is called what? That one is squeezed out is called what? Stroke volume. So meaning that if I want to know the amount of fluid that is in this guy after diastole, it's the same amount that they press out and the one that is still remaining. If you add the two of them, you get the full one. So if they give you stroke volume and give you end systolic volume, just add the two of them up, you get the EDV. And if they give you EDV and they give you stroke volume and they say find end systolic volume, you laugh now. You have given me the thing that fills it, right? And you gave me what they pushed out. So what is remaining? If I give you 5 oranges and I told you to throw away 3, how many is remaining? It's 2. That 2 is the ESV because you threw away 3. And that 3 you threw away is your stroke volume. So if I want to know how many oranges I gave you, I just add the one you threw away and the one you are still holding. That one you are still holding is the ESV. The one you threw away is the stroke volume. So the amount of orange I gave you is 5. The one you are holding 2 and the 3 that you threw away. So the one you are holding ESV plus stroke volume, the one you threw away, gives you what? EDV. So what I need you to do is, you can, after this class, just go back. You understand? This is 253. Go there and listen again. Listen to it 10 times. Trust me, you get it. You understand? What is the difference between stroke volume and cardiac output? Now, stroke volume and cardiac output, remember I told you stroke volume is immediately that guy is squeezed out. That one is squeezed out is stroke volume, right? If you calculate all those stroke volume for 1 minute, all the stroke volume for 1 minute, do you understand? If you calculate all the stroke volume for 1 minute, it gives you cardiac output. Think about it. For example, if stroke volume is 60, It's yeah, 60, for example. How do you know the cardiac output? How do you know how many beats? We already know that the normal beat is around 70, correct? Uh-huh. And each beat, you understand, in a minute, you understand? So that's 1 minute. Each beat is the heart pushing out blood. Each beat is pushing out blood. It means that it pushed out 60 mils 70 times. That's what it means. 60 mils 70 times. Sorry, I forgot what I was saying when I mentioned that. So just remind me, all right? So I'm comparing cardiac output and stroke volume. Stroke volume is, every beat, it pushes out blood. That blood it pushes out every beat is stroke volume. How many times does it push out blood in 1 minute? 70 times, right? Multiply that 70 times that it push out blood in 1 minute by that stroke volume. It will give you cardiac output. So cardiac output is stroke volume times heart rate. Heart rate is 70 beats per minute, right? And each beat it pushes out blood. Each beat it pushes out blood. So we want to calculate how many amount of stroke volume it pushed. How many amount of blood was pushed out of the heart. That's cardiac output in 1 minute. If somebody doesn't get this cardiac output thing and comparison with stroke volume, tell me. The clearer you get it now, the better for you. So that when you are done with this course, you go and watch Netflix and chill. If you get it, tell me got it, so that we move. If you don't get it, tell me emergency. So to clarify, stroke volume is 70 mil. If heartbeat is 70 per minute. Yeah, yes. So stroke volume is the amount of blood that comes every beat. You understand? So watch it. If the heart beats 1, 2, 3, 4, 5, 6, 70 times, each of those times, the blood that comes out from the heart is stroke volume. Each of those times is stroke volume. Each of those times is stroke volume. Each of those times is stroke volume. So if you keep calculating, and we say it's 60, right? That's what you guys said, 60, right? So if we calculate 60, 60, 60, 60, in that 70 times it beats, it will give you cardiac output. So that's why cardiac output is equal to stroke volume times heart rate, because heart rate is that beat. Can you explain from here? I got confused. Yeah. So I'm almost writing on my wall. So loop dupe, it pushes out blood. Pushes out about 60 mils, right? So write 60 mils here. Loop dupe, it pushes another 60 mils. Loop dupe, pushes another 60 mils. Loop dupe, pushes another 60 mils. In 1 minute, how many loop dupes do you get? You get 70 loop dupes in 1 minute. Standard. Correct? Aha. In each of the loop dupe is 60 mils. So that's 60 in each of them for 70 loop dupes in 1 minute. Add it up, it will give you cardiac output. So cardiac output is the amount of fluid that comes out in each loop dupe in 1 minute. In the loop dupes in 1 minute. So you calculate all the loop dupes. Each loop dupe pours out 60 mils. Each one 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 pours out 60 mils. Thank you. So if you gather all the 70 loop dupes in 1 minute, add it up, it will give you cardiac output. So we've discussed ESV, EDV, SV, cardiac output. You cannot forget, though. If you're in this class, you can never come and forget. This is what I need you to have in your fingertips. Do you understand? Go explain it to your partner. Use it to do romance. You guys have to be anatomically romantic. You're welcome. Okay. This slide is even. I've passed beyond this slide now. These are still talking about asymmetric this thing. So look at this picture later at your time. It's called the Wiggers diagram. It has everything in one. All right. What if you don't have one? I refuse to enter that discussion. So later, you guys should also look at these volume changes. I've already explained it. It's exactly what we just discussed right now. I've already explained it. Yeah. So, say what if you don't have one? Yeah, so funny. Okay. Overview of volume changes. Okay, so okay, guys. What of so I can't be romantic and still rational. So people that are romantic, they're irrational. I was not the one that said it though. Please, people should not come for me. See the man, this is the man that said it. I didn't say anything. Okay, guys, we're about to round up actually. So so let's kick it. Now, if blood is not pushed out as it should push out, if the heart is made that you have to be having stroke volume of 60, and instead of 60, you are having stroke volume of 30. What does it mean? It means that there is extra 30 mils that remain in the heart. Your EDV will increase. Sorry, your EDV is the same thing rather. Your ESV will increase. Remember, ESV is the amount of fluid in the heart after you've pushed out fluid. That's ESV. So, but if the fluid you push out is not enough, you understand? For example, if ESV, EDV is 130 as we discussed, and you pushed out 60, you're having ESV of 70, right? But if EDV is 30 and you push out what? 30 instead of 60, what is your ESV? ESV becomes 100. It becomes a problem. That is when we talk about congestive heart failure. Remember I told you, when you are not able to push out blood that you are supposed to push out, sorry, somebody sent me an email. I don't know why they are so stressed about the exam. They have this exam today also. So, what am I even saying? Okay, yeah. So the blood remains in the heart, right? Excess amount of blood remains in the heart. What do you think will happen over time? Over time, the blood will keep going backwards and backwards just because it's not ejected fully. And that's what we call what? Regurgitation also. What can cause this? We call it congestive heart failure rather. What can cause this? Usually myocardial infarction. Some part of the muscle is not able to contract and push out blood. Also hypertension, chronic hypertension. The vessels are suffering, so blood is not being able to push out properly. Valvular insufficiency or even congenital heart defects. All these things can cause what? Congestive heart failure. Heart failure being congested. Now, what happens in congestive heart failure? There are two parts of it. It can be left, it can be right. Guys, I need you to reason with me. If it is left heart failure, right? What happens? Left. Ventricle is supposed to push out, left ventricle is supposed to push out blood to the aorta, right? If it doesn't push out the blood to the aorta, the blood goes back up to where? The left atrium, right? The left atrium takes blood back to where? Guys, give me the answer. If you are going backwards, the left atrium takes blood to where? Quickly. At least 5 people should put an answer. Even if the same thing, that's fine. Going backwards, left ventricle pushes out blood to the left atrium. Left atrium takes blood back to where? Keep going, guys. Keep going. I need to keep going. What happened? Is it that you did not hear my question? I said Only two people commented. I said, if blood is going backwards from the left ventricle, it goes back to the left atrium. From the left atrium, where does it go back to? Exactly. You guys are so correct. The lungs. It goes back to the lungs. Guys, do you know the disadvantage of blood packing in the lungs? Did you drink water? If you drink, okay, let me give you an example. I did surgery. I did the surgery was almost 5 hours. Yeah, 5 hours plus. And I was completely knocked out, right? I was completely knocked out. They gave me GA. You understand? And before the surgery, okay, before the surgery, they asked me not to eat from 8 p.m. of the day before. So I didn't eat from 8 p.m. of that day till I did the surgery. The surgery was the next day. The surgery was like 1 to 6 o'clock, right? Inside the theater before they start doing. I don't know. You understand? So they told me not to eat. Why they told me not to eat is because of aspiration. Normally, you can aspirate, right? You can be drinking water and water will enter your lungs. What do you start doing? You start coughing. Small water, little water. You keep coughing until you push out that water out. But when you are under GA, most of those lungs are paralyzed, those muscles are paralyzed, that you need to cough. Because coughing muscles, you need a lot of things to cough. Thank you. You can choke under anesthesia. So when you eat something, that thing is still in your tummy, and the sphincter, the lower esophageal sphincter, will dilate, which will relax because it's under anesthesia, and things in the tummy will come up outwards. But when they're coming up outward, they will not come out through the mouth. Most times they will not come out through the mouth. Instead, they will go through the laryngopharynx into the lungs. And when they go into the lungs, you are paralyzed at that moment. You can't cough. The person will choke and die without anybody even knowing it. Which is one of the reasons why we put the monitor, because the monitor will the monitor will show that this person is dying. To be on the safe side, me, I did not drink water. They told me don't drink water, don't even chew gum. I was laughing. I said, these people don't understand that I've been in the theater a lot. Me, I did not even dream of eating food because I'm afraid that if I dream where I'm eating, that food may actually go into my tummy. Yeah, I cannot come and die now. If I die, who will be teaching you now? Think about it. Think about it. If I die now, who will be teaching you? So that's why it's, I had to obey them. I had to listen. Can you guys hear me? I need to be sure that I'm very audible. Can you hear me? Perfect. You can hear me. Perfect. Okay. Perfecto. So that's so left ventricular heart failure. You understand? What usually happens is that the blood will go back from the left ventricle into the left atrium and will go into the lungs and sit. If it goes into the lungs and sits, guys, what do you think will happen? The person will start what? Choking. The person is not able to breathe properly. You understand? The person will start choking. He cannot breathe. You understand? That's why you see shortness of breath. So if you see somebody with heart failure having shortness of breath, it's usually left ventricular heart failure. That's how we know these things. You see the person, and the person comes to the hospital, and the person will breathe in. Do you understand? Stressing to breathe. Jesus. If you've been around these people, you say, God, thank you for giving me good health. Even if you don't have money, even if you don't have a relationship, just be happy that you have good health. Because somebody said, what if you don't have? God. Yeah. So, sorry. So that's left ventricular heart failure. Now let's go to the right ventricular heart failure. Think about it. If blood in the right ventricle goes back up to the right atrium, where do you think that blood is going to? Somebody say amen. If blood goes back, we discussed the left. If blood goes back to the right atrium from the right ventricle, where else is it going to? My people, talk to me now. Want to forsake me? Are you tired? I would have given you a break, but we are almost done. So let's just finish up so that I can leave you once and for all. Thank you so much. So it goes back to the vena cava, how it entered. Starts going downwards. When it goes downwards, what does it cause? It causes edema. It leads to edema. Edema, things that pushes out blood, we start holding too much blood, like the liver. The liver will become enlarged. Ascites will happen. Abdominal cavity will become enlarged. This JVB will become enlarged. The jugular venous distension. This jugular vein will become distended. You know what distension is? You know how varicose vein happens, right? Varicose vein happens because of blood going backwards. That's exactly what happens. So just think about varicose vein in the neck. That's what jugular venous distension is. If you see it, you see swelling. You understand? It's not bump. Oh, you see swelling vein. You say, this person had heart failure, right heart failure, blood is backing up. Oh, edema, leg is swollen, tummy is swollen, sometimes liver is swollen. That's ankles is swollen. That's right heart failure. The person will be breathing fine because the left heart has no problem. At the end of the day, it's and end up leading to total heart failure. Complete total heart failure. You understand? I hope all of you understand these concepts. So I've discussed the cardiac outputs. I don't need to discuss it anymore. So go look it up. Tachycardia, you know what tachycardia is. Resting heart rate above 100. Bradycardia below 60. That's why I always say normal is between 60 and 100. All right? Exactly. So there's something called positive chronotropic. Positive chronotropic factors that raises the heart rate. Negative chronotropic are factors that lower the heart rate. Do you understand? Autonomic nervous system occurs. I hope you guys still remember what autonomic nervous system is. Autonomic nervous system, we have in the CNS, we have, or rather in the neuron and in the when you discuss the nervous system, when you discuss the nervous system, we said that there are some that the information goes up to the CNS interprets and it comes back, right, to the effector. So the sensory takes information to the CNS, the motor brings information back from the CNS. I hope you understand that. Now, remember, these are divided into two types based on the tissue involved. Two types based on the tissue involved. First of all, fundamentally, sensory takes information to the CNS, motor brings information back from the CNS. Now, we defined it in two different patterns. One is that information is taken to the CNS or bringing back to from the CNS. Where is it going from and where is it coming to? If it is going from the skeletal, is stuck? Am I stuck? Guys, I don't think I'm stuck. My hand is moving now. Can you see my hand moving? No, I'm not stuck. So if it's stuck, it's your computer. I think you should change computer. I was using this other Samsung computer. I used it for years, a lot of time before it started lagging behind. I suffered a lot last semester because it was lagging behind. But this one is okay now. This one is going very well. Okay, guys. So let me go back to what I was explaining. Sensory goes to the CNS. Motor brings back from the CNS. It depends on which tissue is it going from and coming to. Now let's divide the tissue into two. We have the smooth and the cardiac in one place. I can't hear anything. It's stuck. I can't hear anything. Then it's your computer. I think you should refresh your computer. All right. It's not from my end. Everybody can hear me and everybody can see me. So it's from your end. So I think you should refresh quickly and join back immediately. We're using the same link. So what was I saying? No. Okay, yes, I was talking about the autonomic nervous system. Perfect. So you see, so information going to the central nervous system is sensory. Information coming from the central nervous system is motor. Now, yes, motor neuron. So let's divide it into two. Skeletal tissue is one. Smooth and cardiac is one. Information going from the skeletal. You understand? From the skeletal. So the skeletal is somatic. So information going from the skeletal is known as what? Somatosensory. Somatic is because it's skeletal. Sensory is because it is going upwards to the CNS. That's the meaning of somatosensory. Hit your head and say wisdom, 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 wisdom. Keep hitting your head. Keep saying wisdom so that it will enter. That's the secret. So that it will sink. Keep saying wisdom. So information going, as far as it's going from the skeletal to the CNS, skeletal is somatic, CNS is what sensory, so it comes on somatosensory. If the information is coming back from the CNS to the skeletal, it becomes what? Visceral motor. Visceral because, it becomes somatic motor. Am I crazy? It becomes somatic motor. Somatic motor. So when you say somatic, you say, oh, somatic is skeletal. Motor means it's coming back. Automatically, you know that, oh, this is information coming back to the skeletal tissue or muscle. Somatic motor. Somatic sensory, that's somatosensory. Sensory goes up. Somatic is, yes, somatic. Oh, that means that information is going from the skeletal to the brain, to the CNS. You understand? Somatic motor is coming from the CNS to the, now let's talk about the other part. So the other part, if that information is going from smooth muscle or cardiac muscle to the CNS, it becomes a visceral sensory. Sensory means it's going upwards. Viscera is where it's coming from. It can be either cardiac or smooth muscle. If that information is coming backwards from the CNS to the cardiac or smooth muscle, it's called what? Visceral motor. You need to know these four things I mentioned now. That visceral motor is what we call autonomic nervous system. You see all these things we are saying, autonomic nervous system, every time autonomic nervous system, it's just talking about visceral motor. You should remember it. Autonomic nervous system is what? Visceral motor. That visceral motor is now divided into two. Sympathetic and parasympathetic. Sympathetic is when the information coming down is telling it, activate. Parasympathetic is when the information coming down is saying, don't activate, depending on where it's going to anyway. Hit your head and say, wisdom, wisdom, wisdom. Wisdom wants to choke you. So that is why I'm describing this is because this is what autonomic nervous system is about. But mind you, the autonomic nervous system, does it initiate heartbeats? No. What it initiates heartbeats is the pacemakers. The only thing it does is that it modulates it. It can make it go faster or lower. This information coming from the brain, where does it come? It comes from the cardiac centers in the reticular formation of the medulla oblongata. That's why I told you it is what visceral motor is coming. That's what autonomic nervous system is about. Where is it coming from? It's coming from the medulla oblongata, specifically the reticular formation of the medulla oblongata. Remember what the reticular formation is? I told you, okay, I didn't teach you guys neuro. Jesus. Jesus. I didn't teach you neuro? Oh, God. Oh, God. Let's go and watch neuro. Let me not explain too much. I'm taking too much time. Anyway, so it can have cardiostimulatory effect or cardioinhibitory effect. So some neurons come in a sympathetic pathway to cardiostimulate, to stimulate the heart. Some neurons come from that pathway to cardioinhibit, and that is what we call parasympathetic. And those ones that come to inhibit, they come, the transporter, the vehicle that brings that information is what the vagus nerve. Let's start with sympathetic. As I said, I didn't teach you neuro, but if I taught you neuro, I told you that all the postganglionic sympathetic, because sympathetic has preganglionic, postganglionic. Parasympathetic has long preganglionic, short postganglionic. You understand? So post and pre and post. Each of them has the neurotransmitter they transmit, right? So all the preganglionics, they produce acetylcholine. And for parasympathetic, the postganglionic also produces acetylcholine as a neurotransmitter. But sympathetic preganglionic only, sympathetic postganglionic only, its fibers are adrenergic, not cholinergic. These other ones, like parasympathetic, the pre and the post is cholinergic. The sympathetic, the pre is cholinergic, meaning that they produce acetylcholine. But only the postganglionic sympathetic is adrenergic because it releases what? Epinephrine. That's why it causes action. Why? Because it binds to the beta adrenergic fibers in the heart. And when it binds, I need you to learn this sequence. The norepinephrine produced by the postganglionic of the sympathetic produces norepinephrine as its neurotransmitter. That neurotransmitter binds to the fibers of the beta adrenergic fibers in the heart. Immediately it binds to that beta adrenergic fiber. This is the sequence, because they can give you a equation of sequence. Tell you, oh, and organize it. Then you organize. Honestly, you see the options. Options have different organization. You need to know which one is correct. Postganglionic, adrenergic, uses postganglionic sympathetic uses adrenergic fibers. Those adrenergic fibers, they release norepinephrine because they're adrenergic. Norepinephrine, that's catecholamines produced in the adrenal medulla. If you remember, adrenal medulla produces catecholamines and also small quantities of dopamine. All right, so they work with adrenergic fibers. So when that norepinephrine is released, or for example, you see that EpiPen you guys have, EpiPen. Somebody's having an emergency, you inject that person EpiPen. What does that EpiPen do? That EpiPen contains norepinephrine. That's what we are saying right now. No, it contains norepinephrine and epinephrine. That's why it's called epinephrine pen. You inject the person, check them. So what happened immediately? That thing you injected the person, we immediately go to the heart and bind to the beta adrenergic fibers in the heart. When it binds to the beta adrenergic fibers, what does it do? It will activate a second messenger. Always put it in your head. Second messenger is always CAMP. You must remember it for your exam sake. Second messenger is always CAMP. So these second messengers will be activated, you understand, in the cardiomyocytes. Immediately second messengers are activated, calcium channels will open in the plasma membrane. Immediately calcium channel opens, what will happen? Guys, do you remember? Calcium channels causes what? Depolarization of the SA node. Remember, the SA node. Remember, that's the pacemaker. We mentioned that, from minus 60, slow sodium channel keep going up, slow. Then immediately it gets to minus 40. Fast calcium, fast sodium enters and shoots it up, depolarize it properly. This is exactly what happens. So when you give that EpiPen, You understand? Immediately it will bind to the beta adrenergic fibers, activate CMP. Immediately CMP is activated, you automatically tells calcium, fast calcium, to please help us. This person is dying. That fast calcium immediately causes depolarization. Do you understand? Cause depolarization, cause contraction immediately. And immediately causes contraction. What happens? Stroke volume increases. You understand? Everything starts happening. That's the idea of that EpiPen. That's how epinephrine works. You must remember this sequence. That's sympathetic. The parasympathetic works with vagus nerve. I told you, everything parasympathetic is cholinergic. I told you. And cholinergic has inhibitory effect on the heart. But cholinergic neurotransmitter for muscle has stimulatory effect because that's what causes contraction. But for the heart, it has inhibitory effect. And how does it inhibit the heart? Acetylcholine, it produces acetylcholine, which binds to muscarinic receptors. Those muscarinic receptors will cause potassium to open. When potassium opens, what happens? Potassium will go out. That's why I asked you that time. Do you know anything about potassium? Yes, potassium is intracellular cation ion. So immediately, this cholinergic, the parasympathetic, whatever, the acetylcholine binds to the muscarinic receptors. You understand? It will cause potassium to what? Open. Potassium, when the channel open, it doesn't come in. Instead, it goes out. And when it goes out, what does it lead to? It leads to repolarization. Slowing the heart down. The heart slows down the more. You need to understand this thing. So when you see cholinergic acetylcholine, your mind doesn't fly. Acetylcholine in muscle contracts, but in the heart, it relaxes. And how does it relax? By opening potassium channel pump. That is all you need to know. But when you're talking about sympathetic, just remember that sympathetic, has adrenergic, binds to beta adrenergic fibers in the heart, activates CMP. CMP activates what? Calcium. I already told you about calcium. And once it activates calcium, everything starts happening. Influx of calcium. Depolarization happens. I'm sorry. Keep quiet, this phone. Oh, Jesus. So that is it. Anybody has a problem? So this one is just talking about the baroreceptors and the chemoreceptors. Baroreceptors are the things that senses what? Pressures in the heart, like blood pressure. When your blood pressure increases, baroreceptors senses it, signals to the brain, and you understand. Then the brain sends information back to the heart and tell the heart to to decrease or increase. All right. Chemoreceptors is chemicals like pH, CO2, oxygen level, how it affects the heart. So this is electrolytes. Now, what electrolyte has the greatest chronotropic effect, right? We said potassium, because potassium is inside. You understand? Potassium is inside. So when there's hyperkalemia, that's high level of potassium. Hyperkalemia, high level of potassium, diffusing inside the myocyte. What will it mean? It will make the myocardium less excitable, heart slows down. Remember, potassium is inside the cell, so it's making the cell more negative. That's what you should remember. Everything about potassium is about getting the cell more negative, dropping the heart rate. That is why, if you watch all this movie, you see these assassins, they'll go to the hospital and inject potassium chloride in the drip, and the heart crashes immediately. So even if you want to inject potassium chloride in the clinic, I don't think all nurses are certified to. There are special nurses that do it, and the doctors, right? You inject it slowly in that patient, slowly. And if you put it in the drip, you have to write it on the drip set, potassium chloride. Because a nurse can take over duty and come and, this drip is going too slow. And she will increase it, or he will increase it. And once you increase it, it kills that patient. So if you put potassium chloride on a drip set, you must write it KCl. If not, you crash your patients. All right. So another one is calcium. Calcium. I don't know. My pronunciation is terrible. Calcium. We have hypercalcemia. We have hypocalcemia. Hypocalcemia is deficiency. Hypercalcemia is increased. When you give too much calcium, it's common sense. Exactly. So the sodium is outside. Too much calcium is common sense. It's you keep contracting. You understand? Increase high contraction. Now, guys, stroke volume. What determines stroke volume? What determines the amount of fluid I'm going to press out of this thing. Do you remember what stroke volume is? Amount of fluid you press out for every loop doop. It's different from cardiac output. Cardiac output is the amount of fluid, all the loop doop pressed out in 1 minute. Okay. Perfect. Don't worry, we're almost done, guys. We are very, very almost done. 3 variables govern stroke volume. 1 is the preload. 2 is the contractility. 3 is the afterload. Guys, just relax. Don't think too much about this thing. Don't even do anything. Just focus. Let me make you understand what this thing is. As when I'm in class, I would have demonstrated it more. But yeah, look at it. You know what contractility is? Digging. If contractility increases, the amount of fluid that will be pushed out of the heart will increase, correct? So contractility, increase in contractility increases what? Stroke volume. Make sense? Yes. Contractility out of the equation. Preload. What is preload? Preload is anything before the heart. Preload. Anything before the heart. So like fluid coming into the heart is preload. So if there is a lot of fluid coming into the heart, right? That means the preload has been what? Increased. There's a lot of fluid coming into the heart, is increased preload. So if a lot of fluid coming into the heart, what will it cause in the stroke volume? Will it increase the stroke volume or reduce the stroke volume? Will it, if, how do I explain this thing? Okay, for example, I pour in 130 mils, right? I pour in 130 mils and 60 came out, correct? Stroke volume, 60 came out. I pour in 130 mils, 60 came out. That's stroke volume. Now, I decide to pour in 300 mils of fluid is coming in at the same time. Will what is coming out, will it still remain 60 or will it increase? Okay, somebody said increase. Let me see. Keep going, guys. Chat, keep going. It will increase because you are normal. That's physiology. Yes, you are normal. It will increase. Perfecto. Because of more pressure. I love you too. You understand? So the more fluid that enters the heart, the more stroke volume. And I told you that more fluid that enters the heart is preload. What does it tell you? It tells you the greater the preload, the greater the stroke volume. The greater the contractility, the greater the stroke volume. 2 down, 1 more to go. So what is afterload? You see, you want to go forward. I want to press this thing forward and something is blocking it. Blocking it. I'm pushing it, blocking it. So let me ask you, if this thing that is blocking it, the pressure in this thing, this afterload increases, the pressure increases, the stroke volume that is supposed to come this way, will it increase or decrease? Think. You know, in the clinic, it's practical. Clinic is more like what you know. You have to think. It's not. What is in the book is in the book, but you need to think. If something is blocking you now, you can go forward, right? You can push that thing out and keep going, right? If that thing that is blocking you is increased, will it increase your chances of going or reduce your chances of going? Decrease your chances of going. Which one? Decrease? Let me see. Let me see what more people say. Keep going, chat. Keep going. Perfecto. I mean, that's how I need you to think in the exam hall when they ask you preload, contractility, afterload. All you need to know is what it is, and you'll be able to know, and you know what stroke volume is. So if the pressure up in front is too much, this stroke volume will be low. But if the pressure is low, the stroke volume will be high. That is how the three of them works. All right? So the question is that what can increase preload? What can increase fluid coming into the heart? One is exercise. You understand? One is exercise. So when you are exercising, a lot of fluid is entering your heart. And at that moment, a lot of fluid is what going out. So anything that can increase contractility. That's why Frank Sterling has this equation. He says stroke volume is directly proportional to EDV. What is EDV? EDV is the amount of fluid that is entering the heart at a time. Remember, EDV, end diastolic volume. If the end diastolic volume is increased, what happens to stroke volume? It becomes increased. That's exactly what we just said now. Directly proportionality. But normally, if you see this Frank Sterling law, you'll be trying to cram it. You don't need to cram it. We already mentioned EDV. When the thing opens, the fluid that enters inside. If it's too much, that means the fluid that will go out will also be too much. That's exactly what they're saying. Exactly. Okay? And this is contractility. These are the things that can increase contractility, you know, like hypercalcemia, catecholamines like epinephrine, they can increase contractility. Even drugs like digitalis, which raises intracellular calcium. Even glucagon. Glucagon is the hormone that converts glycogen to glucose. It can also stimulate CMP production. And remember, CMP leads to increase in heart rate. You understand? Because it causes depolarization. All right? Then these are negative inotropes, right? Things that reduces heart rate. This is afterload that we just discussed. Afterload, some of all the forces opposing the ejection of blood from the ventricle. You understand? Opposing it. Like the pulmonary trunk and the aortic trunk, their pressure is high. That pressure is opposing the pressure that you have to pump out blood. And because of that, your blood pressure has to be able to overcome it. That's why, you know, that systole is about what? Around 120. Because of that, the pressure is higher than the diastole. Why? Because it has to get the pressure enough to be able to push through those pressure vessels, which is aortic and the pulmonary. So they limit stroke volume. Hypertension is also something that increases afterload. So guys, in your question, anything that increases afterload, does it increase stroke volume or reduce stroke volume? Anything that increases afterload, does it increase or reduce stroke volume? Let me see. I don't need you to think. I need you to just give me an answer. Anything your answer is correct. So let's go. What did I even ask? Anything that increases afterload, does it increase or reduce stroke volume? Come on, guys. Come on. I need everybody to attempt. Listen, the more you attempt, the better. If you fail it, you learn that I failed this thing, I'll correct myself. Oh, I got this thing. Okay, I know it. But if you don't talk, then that's a problem. Don't think. So guys, think about it. We said afterload. If afterload is increased, stroke volume is reduced. So I said anything that increases afterload definitely will reduce stroke volume. Make sense? What are the things that can increase afterload? Things like what? Hypertension. Exactly. So hypertension, we have to decrease stroke volume. Yes. Okay. And anything that increases circulation will definitely increase afterload. Like what? Like copomulel, emphysema, chronic bronchitis, and black lung disease. All of them, they increases afterload. All right. And once they increase afterload, they definitely will decrease stroke volume. And when stroke volume is decreased, it means that blood is now staying in the heart more than it should, leading towards failure. So this is exercise. I'll look it up later. So this is CAD. Guys, we already discussed coronary artery disease. You understand? We already discussed it. A lot of things happen in coronary artery disease. Now, I discussed angina pectoris with you initially. right? For me, I hardly ask pathology questions in exams. So bear that in mind when you are studying. All right. Um, so this is LDL. We've already discussed this thing. So I think that is it. So these are avoidable risk for coronary artery disease. Look at it up. There are things you cannot avoid, like heredity, like aging, like being a male. You can't avoid it. You understand? There are unavoidable risk factors, but there are preventable risk factors like what? You can prevent obesity. You understand? Smoking can prevent that. Lack of exercise, you can prevent that by going to the gym and giving them your money, like me. As anxious and personality, you can reduce anxiety, unnecessary anxiety. Some people are just unnecessarily having anxiety. You understand? Then stress and aggression and diet. Just nature. Honestly, just nature. Also, treatments, coronary bypass surgery, ballooning, and insertion of stents. So please, you don't know who has who had a bypass surgery or balloon. You understand? Or laser angioplasty, and you want to go and fight the patient. It becomes a problem. All right. So I think this is the last chapter, guys. So guys, you guys are the best. So how many hours did this spend? 3 hours, 41 minutes. Okay, that's fair. That's fair. So at least you have more than an hour plus to study. Yeah, all of you are here, so your attendance is fine. Let me see. Hold on. Yeah, you're welcome, guys. You're welcome. I'm happy that I didn't miss out taking this topic, because initially I wasn't feeling too well. I was even discussing with the doctor yesterday that I really don't feel well. I feel sick, like seriously sick. So he said it's the anesthesia that I'm having. They gave me too much or too. I don't know what he was talking about. But he's a wonderful person. He's even a friend. So he said they gave me too much, not too much, but they gave me a large dose, so that it's possible that it's still in my system, and that's what is making me sick. So, and that's what is making me sick. Hold on, I need to snap this. So he said that's probably that with time I will be fine. Thank you so much. No, I'll definitely see you guys next week. Oh. Someone sent me a message. I said, Professor, you are not well. Are you sure you have to come next week? Are we going to write exam? Said, yes. I don't miss lectures. Honestly, I really don't. You can ask everybody that have been in my class. Never. I like seeing your faces. Ah, ah. This is how I know people that were not here when we started. He said, what exactly do we review? Just everything from yes, everything from the 3 chapters. I posted an exam one review for you. Go and watch those videos. What for me, as many questions as possible. How many questions will be on the exam? It depends on the spirit. Spirits can just minister unto me that day. It can be 100, it can be 50, it can be 70, but not more than 100. Normally, the exam is 150. So that means that's why you need to read very well. Read as if it's your final exam. And if I'm you, I will go online, check all the reviews. I've done the reviews for more than 3 classes on this same thing. Go look at those videos individually, so that there may be like some 5 questions or 10 questions I didn't review with these other people. You are able to capture all of them. Do you understand? Yes, it's the spirit. The spirit is just minister to me and say, Nchebe, my son. I say, yes, father. Nchebe, my son. I said, yes, father. Today, give them 74 questions. I said, father, let's just round it up to 70. He said, no, make it 80. I said, okay. Your word is my command. That's how the spirit. You guys don't understand. That's how the spirit talks to me. You don't know. Uh-huh. He said 70 is cool. I didn't say anything. No. It can be any number. Listen, guys, the higher questions you have, the better. Do you understand? I can decide to give you 10 questions, but one question we have 10 marks. So if you mistakenly say one question, fail one question, you already fail 10 marks. You see, it becomes a problem for you. You understand? But when you have a lot of questions, it's easier for you to pass. Exams that have a lot of questions is easier to pass because sometimes you may see another question and you remember that, okay, this other question I answered is wrong. I have to go back. Because and when you're coming, come with your gadgets. You understand? Come with your gadgets because it's you do it on computer. So let me go talk to them spirits. No. Use that time you want to go and talk to them spirits and go and watch those videos, please. I'm telling you. Watch those videos. You can even write down those questions and review them because you will get something very similar, extremely similar. All right. So that you don't blame yourself and say, "Hey, assuming had I known, I would have started doing this thing in first exam." You have chance to start now. Do you understand? I just don't want you to pass, but I want you to know it. But you being in this class, I am sure anybody that was in this class for this almost 4 hours, there's no way you can tell me that you don't know these things now in your hand. I will fight you. I don't know if you have stents or if you have this thing. I will fight you. Okay, guys. So let me leave you, all right? I'm going to sign off. If you have a question, you can drop there. How much is the midterm and final exam? And final. Please, this is not what we discuss here. We'll discuss those ones in class. So if you have any question, you can ask me that's related to what we discussed today. If not, I'm going to sign off in the next 30 seconds. 1, 2, 3. I'm counting to 30. That's how I always end my videos. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Don't worry, I know you guys are present. I know. Don't worry. I have the record. It's not a problem. I have the record. If I come to class, I'll call all these names and you tell me I will not mark it. All right, take care, guys. I'm gonna sign off now. Bye-bye. Where do I even end this stream? Yes, bye. Thank you. Put me in your prayers, so I appreciate it.